All right, so we did patient assessment last night. Know that that is a lot of information, especially for you reading the chapters. Um, the test is kind of difficult because there's so much information. The lecture is misleading. So um, there's no way to really lecture all the details on that. So you're definitely gonna have to read that chapter especially. But tonight we're gonna go over airway management. What we are talking about here is basically the A in your ABCs. So we're gonna be going over a lot of ways to make sure that we keep a patent airway. How do we do that? What are some of the tools we've got? Why are we doing that? How do you know where somebody may be having a problem with their airway? That kind of thing. We're going to talk about oxygen cylinders. Uh, but a lot of the stuff you're going to see through the slides is skill based. So we're not going to, some of the stuff we're going to skip over tonight. And it's not because we're just saying that you don't need it or anything, but it's because you're going to do this hands on when we go to the boot camp. So we'll talk about it. We'll definitely hit all the academic stuff in it tonight, and then I'll kind of go over an overview of what you're going to be doing with the hands-on when we get to the boot camp. But hopefully some more people come in as the night goes on. If not, that's all right. We do have the recording going. So let's get this show on the road. This is actually a chapter that some people, well, I won't say some, a lot of people struggle with. And it's because it's a lot of information that you tend to overlook. It's not really that hard of a chapter. It's just that the registry can pull a whole bunch of questions from some seemingly monotonous and mundane paragraphs in the book, you know, where you're like, where did this question even come from? So, all right, so anyway, the single most important step in caring for a patient is to address their life threats, right? So, I mean, that's the first thing we do when we show up to a patient. We make sure the scene is safe, um, make sure that we're not going to get hurt trying to get to them. Once we get to them, though, the first thing we want to do is address their primary life threats. So that's our ABCs, making sure they're not going into shock, bleeding out, not able to breathe, that kind of thing. And unless it's a cardiac arrest, we start with airway. So, excuse me, when you get to your patient, making sure that they can breathe is one of your biggest things. So you know, if they're laying face down in a ditch full of water, we don't want to leave them there while we're trying to do everything else. First thing we're going to do is get them up out of the ditch on their back where they can have a good route, hopefully from outside the body and airflow into the lungs. When your ability to breathe is disrupted, obviously oxygen delivery to the tissues and cells are compromised. Now, when we can hold our breaths, that's not a problem, right? People do it all the time, whether they're stubborn kids or people going swimming. Um, that's not a big deal. But when you're unable to breathe, especially for an extended amount of time, you know, things really start to go wrong, and the heart and the lungs tend to work together. So if your breathing is stopped and beyond the willful holding of the breath, and I'm talking about like you want to breathe but you can't, the body is screaming for air and you can't do it for whatever reason. When your breathing shuts down, your heart's going to shut down with it. Your cells require a constant supply of oxygen to survive. Can anybody tell me what our percentage of oxygen that we want to aim for is? It's a range. We talked about it a little bit last class. Anybody remember? It's a percentage range. Okay, so that's pretty close to what your breathing rate is. But yeah, so Eileen Murphy is pretty close on it. Megan's close. So it's actually 94 is the minimum. So good job, Megan, on that. You were very close, Eileen. The max is higher than 96, though. Anybody want to try to get the max? 99. There we go. 94 to 99. So basically, the upper 90s is what we're looking at. We don't want to go into the 100% anymore, but we really don't want them to be below 94 unless for some reason the doctor tells you to allow it to happen. Some people just hang out in the low 90s, especially like emphysema patients, patients that are longtime smokers. You may not get them into our ideal range, but the average person, that's what we want to do is 94 to 99. Within seconds of being deprived of oxygen, a lot of your vital organs will start to function abnormally, the big one being the brain, right? Like I said, it's the first thing to start complaining when things aren't right. So if the body starts to lose oxygen, they're going to start to lose their level of consciousness. The brain tissue will begin to die within 4 to 6 minutes, which is a pretty long time when you're thinking about what we're talking about here. Like you said, breaths per minute. Oh, that's fine. Yeah, and I was just talking about oxygenation. So continuing on with the kind of the anatomy, or really more the physiology here. Oxygen reaches body tissues and cells through two separate but related processes. So we have breathing and circulation. Your breathing is what we're going to be talking about tonight, or at least your ability to move the air is what we're going to be talking about tonight. So that's getting the air from outside your body to the bloodstream, and then circulation takes it from there to the cells of the body. So just a quick recap from before: when you inhale, atmospheric oxygen moves into the lungs, and they do that normally by negative pressure. So like I said, think about it, your chest wall and diaphragm are in the resting position. When you go to take an inhale, the diaphragm contracts, which makes it pull down. Your chest wall rises, which makes it pull up. Suddenly you have more space in your chest cavity without any more contents in it. So what we've done is we have dropped the pressure by making the chamber bigger. Now you have atmospheric pressure that comes into your lungs, equalizes out. That's how you get your oxygen in. And then when you exhale, um, your chest wall and your diaphragm relax. They close back together, and now you're basically, you've got X amount of air inside your lungs, but the compartments are squeezing down. So you're creating more pressure. That's going to push that air out of yourself and back into the world around you. When we breathe in normal air, we're not breathing in 100% oxygen, right? Anybody know from college class or anything how much oxygen we actually get when we breathe regular air? Or some firefighters that have taken hazmat classes, things like that. Let's see who can pop this up. It's not 55%. It's a lot lower. Lower than that. There we go. I figured a firefighter was going to grab it. Good job, John. So 19% of what we breathe is actually, and under normal conditions, that's how much oxygen we get from the air around us. Most of the percentage of air, something to the tune of like 70% or whatever, is actually nitrogen. But that 19%, give or take a little bit, that's what we breathe under normal conditions. So you really don't need, I mean, think about it. That's all the percentage of oxygen we need to breathe. And us sitting here in this class, going about our daily life, 19% is perfect. So that's one of the reasons why, like, when we give 100% oxygen, it's great for the body, but if we give too much, it can be a problem because you're making it just fine off of 19%. But the amount of air that gets the oxygen coming into your body is going to be a much higher concentration, even though the air you're breathing in doesn't have that much to it. All right, so we breathe in oxygen with the air, and then we exhale the stuff that we don't use, like nitrogen and all that, gets exhaled out of the body, and carbon dioxide that has been dumped from the bloodstream and into the lungs at that gas exchange point goes out with it. Now, there's a couple of benefits to this, other than the fact that air good, human lives kind of thing. Our body's fastest buffer system to keep our pH balance where it needs to be for all kinds of body processes and just general health of the cells in your body is just a little bit over, the pH is just a little bit over 7.3. So 7.35 to 4.5, that's what we look for. And that's a pretty hard range to stay into if you think about it. So our body regulates that with a series of buffers. The biggest one being your ability to breathe off carbon dioxide. Carbon dioxide is acidic. So your body is constantly trying to maintain that pH balance. And your rate of breathing is based on usually that number. When your pH starts to rise, or well, technically starts to fall into the acidic ranges, your body picks up the breathing rate so that you blow off more carbon dioxide. If you start to turn alkalytic, where you're getting to the higher end of the scale, your body will start to slow down its breathing to hold in some of that carbon dioxide. But if you can't move any air at all, then your body is just going to start building carbon dioxide to a point where you get very, very acidic. We have a term for that in the medical field. We call it acidosis. There's a couple different ways you can get it, but it's not good to get. And that's one of the things that we want to stop from happening. Not to mention, we just need oxygen for our cells to be able to continue to make the ATP that they use for energy. Ooh, wrong way. All right, so the anatomy of the respiratory system. Let's do a recap of this from chapter 6, I believe. Let's look at the upper airway. That's your nasopharynx, which is the mouth or the nose cavity in the area behind it. You have the nasal air passages. The pharynx, the oropharynx. The oropharynx is where your mouth is, right? Oral. You have the actual mouth, the epiglottis, and the larynx. Your epiglottis is actually it's a flap that covers up your airway. That way, when you go to swallow something like a glass of water or steak or whatever, it doesn't fall into your airway and then you choke to death. It keeps that closed, especially when you swallow. It falls into place. The whatever you swallowed moves right by it, and then when your neck relaxes from the swallowing, that epiglottis moves out of the way, and you can get air into your airway again. The lower airway, actually, before we talk about that, remember as EMTs, our playground is the upper airway. All right. Once you get into the lower airway, that means you're past the cords, is what they basically call it. So when you get past the vocal cords, you're in the lower airway. We don't do anything past the cords as EMTs. What we basically do is when we put in an adjunct, we're basically trying to keep the tongue off the back of the wall. That's what we do. If it has to be any better of an airway than that, you need a paramedic to do that. They've given us some new toys as EMTs, which is kind of nice. You get what's called LMAs. Um, and those are kind of like tubes, but they just don't go past the cords. They've got these designed cuffs on them or whatever that when you just blind insertion stick it in somebody's mouth, it lines up with their epiglottis and with their cords. And then when you inflate the balloons, it holds itself in place and air can actually flow through. They're not the greatest, but they're really, really quick. And even paramedics will default to those if that's all they need. You know, I mean, they train them now not everybody needs an ET tube. In fact, if a paramedic gives a patient an endotracheal tube, which goes past the cords, they basically bought them a night in the hospital. They won't send them home in the same day. So even paramedics are trying not to use those airways if they can help it. So they're doing the same thing y'all are, unless it's necessary. Like say it's a burn patient. Anyway, your lower airway, you have your trachea, which goes from the cords all the way down to the carina, which is where your bronchioles branch off. You have your left and right bronchioles, your main stem bronchus, and then you getting down into like really lower airway after that. So you have your alveoli, and that's where your gas exchange happens. The main structures that you need to help you breathe, if you look on the left side, you see the diaphragm, your chest wall muscles. Those are your active breathing muscles. That's what actually moves to help you take a breath. You have some accessory muscles, mostly around the neck, and then the nerves from the brain and spinal cord that run to those muscles are what controls them. Because remember, even though we do have conscious control over our breathing, we also have autonomous control or autonomic, however you want to say the word. Um, that way, if we're passed out, we'll still breathe. You don't want to. Otherwise, the minute you go to sleep, you're going to suffocate. But we worry about, and we get into this later on. We want to make sure that if somebody's got a neck injury, we make sure that they don't do anything that severs those nerve endings, because if they lose connection, then they lose the ability to breathe, and that's it. That's usually what kills people whenever they have a high cervical break. Is it shuts off either their heart and lungs, or either or both. All right, so we talked about the difference between ventilation and respiration. Can anybody tell me the difference between the two? We'll start with ventilation. What is that? We already talked about all these from the picture. Can anybody remember the difference between um, ventilation and respiration? while I get back on the right slide here. Nobody? When a person inhales with ventilation. All right, so yes, so ventilation is actually moving the air. And that's important because if anybody ever tells you you need to ventilate your patient, what they're talking about is you need to actually breathe for your patient using either a BVM or a pocket mask or whatever you've got. But your patient's not taking a breath. So the term for that is they're not ventilating. So if you have to vent your patient, that is you actually pushing air into their lungs and out again. Think about it with a hospital. With COVID when COVID hit, some of the biggest concerns out there were people with respiratory failure, and we didn't have enough vents to go around. Oh, that's fine. So, we hooked them up to ventilators, which basically were pumps. They would just push air into the lungs, and then after a set amount of time, which whatever they set their dials to, it would relax and let the body push the air back out, and then it'd push more in, and so on and so on. We do that similarly as EMTs, but we use different stuff. We use bag valve masks. Or, like I said, you can use a pocket mask in your own lungs to blow air into somebody else's mouth. That's fine. Respiration is the process of exchanging oxygen and carbon dioxide. That is correct. So getting the air in is ventilation, and that's only half the equation. Respiration is the actual exchange, and that is the other half of the equation. All right, moving into the anatomy. We already talked about the upper airway, the nose, mouth, the jaw, oral cavity, pharynx, and larynx. The main function of the upper airway is to warm, filter, and humidify air as it enters the body. If you think about it, when you especially if you guys have ever been, say, like to New York City for New Year's or something like that, where it's just really, really cold out there. If the air is too cold, and let's say you're mouth breathing, or you ran a bit and you're out of breath, you walk outside, you're pulling that air into your airway, your lower airway, before it has time to really warm up. It makes your chest hurt. It makes it hard to breathe. It kind of dries out your airway and that kind of thing. So that's the point of your upper airway. There are little hairs, little surfactant that's on the inside of your airway past the bronchioles. I'm sorry, past the epiglottis. That does the same thing. What it does is it creates this rough edge around the airway pipes, so that as air is moving in and it's not moving straight through, it's getting caught up and causing turbulence, and that turbulence causes friction, and that warms the air up, so that by the time the air gets down to your alveoli, it's typically your body temperature, even though it might be 6 degrees outside or something. So that's what those structures do. Your pharynx is a muscular tube extending from the nose and mouth to the level of the esophagus and the trachea. All right, so again, there's two entrances to the pharynx. You have your nasopharynx and your oropharynx. Your nasopharynx is the upper half where your nose kind of dumps into it. And the oropharynx is the lower half of it. It's where your mouth puts into it. There's your nasopharynx. Your oropharynx is a little bit lower than that. And then your laryngopharynx, which is down around the larynx, where the pharynx and the larynx kind of connect to each other. There's no definite I take that back. So I was going with a different thought. The separation between your pharynx and your larynx is your epiglottis. Once you get past the epiglottis, then you're in the larynx. And that's why they call, like, if a paramedic is having to put an advanced airway into somebody, they use their little scoop device. They call it a laryngoscope. It's because that device allows them to see the larynx. That way they know where they're putting their tube at. Talked about the oropharynx. This is just another picture of the mouth, the oropharynx. The biggest thing that we have to worry about a lot of times with EMTs when we're talking about compromised airways is the tongue. The tongue is huge. You can see it from this cross section on the right. It's a lot bigger than what you see when somebody sticks out their tongue. You're really only seeing the tip and the top of it. When a patient goes unconscious, they lose that muscle control. Their tongue will relax and it'll fall back to the back of their throat. Now, it's really not possible to swallow your tongue. You've heard people say that before. But what happens is that tongue lays onto the back of the pharynx and it closes it off, so you can't get air any lower than that. So what we do as EMTs, it's our job to make sure that that upper airway is patent. We do that with our NPA, nasopharyngeal airway, which we'll talk about in a little bit, the OPA, which is the oropharyngeal airway, and then we have our LMAs, which are kind of like modified advanced airways that don't go past the cords. All right, so talking about the larynx here. It's complex structure formed by many independent cartilaginous structures, so it's not solid bone, but it does still have some structure and rigidity to it. There is a bone there. It's called the hyoid bone. And something interesting about the hyoid bone is it's free floating. It's very small and it doesn't anchor to anything. It's just a solid piece that all of the other tissues of that airway in that area, all of them connect to it. Anybody tell me something interesting about the hyoid bone that you might have heard in a non-medical sense? I'll give you a hint. Medical examiners look at this when they're looking at dead bodies. Lockjaws, good guess. Good attempt. A little bit more morbid, more criminal mindsy. So the hyoid bone, it's very hard. It's pretty protected. It's very hard to break. If you find somebody with a fractured hyoid bone, most likely they were strangled. That's usually the way that that bone gets broke. Um, that's just gee whiz. Obviously, you as an EMT is never going to see that, but that bone is significant to different people in the medical field for that reason. If they're investigating a death and they worry about whether or not this person was strangled or not, they'll look at the bone. They'll do an X-ray of it, and if they see that the bone is fractured, that tells them that there was some significant force put right there. Your hyoid bone is basically it's a big connection to where all the different cartilage from the airway connects. To my knowledge, the cartilage itself protects the bone. That and just its location. It's not something you would typically get hit by because if you look at the picture, it's above your Adam's apple. All right, as a guy, the laryngeal prominence. I mean, women have that same structure, but it's flat. It doesn't stick out. That's why women don't typically have Adam's apples. But the bone itself is above that, so it's very hard to hit. It's not something that you would break or fracture on accident. A lot of times, just because somebody's got their hand wedged in there, or hangings. If somebody tried to commit suicide by hanging, they might fracture their hyoid bone. All right. So anyway, your larynx marks where the upper airway ends and the lower airway begins. Usually, that is with the epiglottis and the cords. The thyroid cartilage forms a V shape anteriorly, especially in males. That's why we have the Adam's apple. That's actually what you're feeling, and that's not real bone. That's just cartilage. The cricoid cartilage. It's the lowest portion of the larynx. That's actually, you can see it right here in this picture, the cricoid, and then below that you have your trachea. Notice this gap here, this fibrinous gap between your thyroid and your cricoid. You have a cricothyroid membrane. If a paramedic ever has to cut into somebody's neck to give them a surgical airway, that's where he's going to aim. Um, this is also important if you're ever assisting a paramedic with trying to put in an ET tube on somebody that's got a difficult airway. He may ask you to do cric pressure. That's where you're going to find the Adam's apple, move your fingers down until you feel the next, I'm going to say bony prominence, even though it's cartilage. When you find that, press down on it. And what it does is it makes the cords flare out. So if you picture the vocal cords as being like a football that's propped up on its end, like it's getting ready to be kicked down the field, that's kind of the shape of your cords. If you press down on it, then the 2 points come together and it flares out to more of like a diamond shape. And when it does that, the paramedic has an easier time because it also pushes it down so the paramedic can see it, but it opens the cords wider so that the paramedic can put his tube between them. Makes it easier for them to get that airway. All right, next up. The glottis is the area between the vocal cords and is the narrowest part of an adult's airway. If something's going to get stuck, that's where it's going to happen. Your vocal cords, we've already talked about those a little bit. They're white bands of thin muscle tissue and they vibrate when air passes through it. That's how we talk. If they're ever severed, then your patient is not going to be able to speak with any real volume. They may be able to get some sound out, but it's not going to be like how we're talking to each other right now. They are partially separated at rest. And again, like I said, sometimes that opening is pretty small. So your paramedic may have you do crike pressure to help them get a tube in. All right, for your lower airway, the lower airway's function is to get the oxygen to the alveoli. So this is where you have your trachea, which runs from the epiglottis down to where it branches off to each lung. Then you have your bronchi. Those are, you have a left side and a right side, and then the lungs themselves. Your trachea is your windpipe. This is the conduit for air entering the lungs, and it goes all the way down. It starts at the cricoid and it goes down to what we call the carina, which is where the fork in the road is. Then you have, like I said, your right main stem bronchi and your left main stem bronchi. And all of this has a little surfactant, like I said, that's inside of it. And that surfactant slowly comes up out of your airway as it's being produced. So it's a constant production and it kind of comes up. And normally we just swallow it down. It's not a big deal. We don't think about it. But sometimes, like if you've heard upper congestion or whatever, a lot of times that's what that is. It's either that coming out of your lungs or it's the sinuses draining down. Moving on. So here's just another picture. It shows your trachea. Your carina is the fork in the road. Then you have your main bronchi going into each lung. If you notice your lungs, we talked about this before, your right lung has 3 lobes, your left lung has 2. So you have a upper on both sides, you have a middle lobe on the right and 2 lower lobes because you got to have room for the heart. Bronchioles are made of smooth muscle. They dilate and constrict as oxygen passes through them, so they kind of like blood vessels. When the air moves through it, they expand out to allow it, and then they condense back down. The smaller bronchioles connect to the alveoli, which look like broccoli, and that is where your gas exchange happens because you have the capillary bed that runs all over every one of the bulbs of each alveoli. All right, so here's another fancy picture that basically shows you the heart and the great vessels, which is your vena cavas and your aorta, are found in the thoracic cavity. But if you notice, obviously, they're not completely just there. Your inferior vena cava and your aorta go down all the way through your abdomen and then continue down into your legs. And that's important, especially when we start talking about pregnant women. If they're laying on their back and they're preggers, so they got the baby puts pressure on the vena cava. It stunts out all the blood return to the heart and can cause their blood pressure to bottom out, and then they'll lose consciousness. So that's an important thing I want to point out while we're here, because we're going to talk about that at great length when we get to the childbirth chapter. All right. So when we talk about body cavities, your mediastinum is the area between the lungs. That's where your heart, your great vessels, your esophagus, your trachea, and your major bronchi and nerves are. The phrenic nerve is also found in the thorax, and this is important because this is what tells your diaphragm to contract. If that nerve is what's broken, then you're not really going to be able to breathe. You can still operate your chest walls, but with the diaphragm not being able to contract down, it'll all just come up together, and then you don't really get good breathing, if any at all. Talking about physiology, I had mentioned before, your respiratory tract and your cardiovascular system works together. So if one stops, the other one's going to stop, and they're in more synergy than that. If you speed one of them up, you're going to speed up the other one. If you slow one down, you're going to slow the other one down. So if you get somebody that's freaking out, and this happens a lot when people are calling 911 because it's an emergency, even if it's only an emergency to them. If you're trying to calm a patient down because his vital signs are through the roof, and you're sitting here looking at what's going on, and in your professional opinion and judgment and everything, you're like, okay, your reaction to this is worse than the problem itself. I need to calm you down. The easiest way to do that is to tell them to slow their breathing. I know everybody's heard that, and it seems really cliched, but it works. All right. Tell them to take slow, deep breaths over, say, like a 4-second count, and then blow it out. And take another deep breath, 4-second count, blow it out. And what you just did is you've brought their breathing rate down to about 10 to 12 a minute, which is the lower end of their breathing rate, what it should be. And then what that's going to do is that's going to drag the heart rate down. We can even use that when we're dealing with cardiac patients. There's a couple of techniques that we can coach people through that will slow their heart rhythm if they're in something called SVTs, for example, supraventricular tachycardia, where the heart's just racing. One of the first things that we try to do is get them to slow their heart rate down. We tell them to, slow your breathing. That's going to help. And then there's some other things that we'll do that we can get them to do, and we'll talk about that when we get to cardio or cardiac. But the systems really do work in tandem together, and you can control somebody's pulse without giving them anything other than some coaching and advice. The process of breathing is broken into ventilation, oxygenation, and respiration. So we already beat ventilation to death. I'm not going to go into that too much. We just remember a couple of things. First of all, we breathe with negative pressure. All right. You're not pushing air into your stomach or into your lungs. You're sucking it in, actually, whenever you take a breath. And that's important, because if you're breathing for a patient with a BVM, is that how they're breathing at that point? Are they sucking the air out of your BVM, or are you pushing it in?
Pushing it in.
Pushing it in.
Which is called positive pressure ventilation. And the issue with that is that when you push it in, they never breathe out as much of it as they usually would. And so the longer you're having to do breathing the longer you have to ventilate a patient, the more their lungs are going to start to hold residual pressure higher than what they normally do. And eventually it's going to get to a point where you can't breathe for them anymore because their lungs are just not deflating. And also, every time we breathe by positive pressure, we get exactly that right there, gastric distension. So some of that air, no matter how good you are with your airway and your seal and all that, some of that air is going to go into the stomach, especially if you've got somebody that's new and they're squeezing the whole bag. We don't squeeze the whole bag, but some people do, especially when the EMT is freaking out as much as the patient is. They don't know. They just, all right, I got this big ass bag in my hand that's going to give air. I'm going to squeeze all of it. The lungs fill up about halfway through. The other half of that bag is going to go into their stomach. And the more that you do that, the worse it's going to be when it all comes out. Yeah, you guys in the chat, y'all know. I've smelled some bad stuff in my career, and that is the absolute worst. That's worse than burning flesh. That is worse than, oh God, any kind of vomit or other feces or whatever. But that is just, oof. We had to take an ambulance out of service for a week to get the smell out of it once, because we had a guy just belch up everything in his stomach during a cardiac arrest. So just keep that in mind. All right. We do breathe through negative pressure. Carbon dioxide enters the alveoli from the blood, whereas oxygen enters the alveoli from the airway. Those two gases swap off. And then when you breathe out, carbon dioxide continues to leave, and the oxygen you breathe in goes to the body. All right, so like I said, we've already beaten ventilation to death. I'm not going to bother with that. So let's talk further. Oxygenation. Give me a second. All right. So oxygenation is the process of loading oxygen molecules into the hemoglobin, which is in your red blood cells. So that is basically what's happening at the alveoli. That is oxygenation. This is required for internal respiration to take place. If the exchange itself doesn't happen, then there is no respiration, and that's what we were talking about. Like if there's a if it's a congestive heart failure issue, then you run into the problem of fluid being in the way, and the oxygen and the carbon dioxide, there's a barrier there, so they can't switch. That's one of the biggest issues with CHF in an emergency setting. That's why one of the things that we try to do the most is create pressure in the lungs and push that fluid out, get it out of the way so that we can get that gas exchange to happen again. Otherwise, it's a heart condition, but it will be a suffocation that causes the patient to die. Ventilation without oxygenation can occur, and that was an example. Respiration, this is the actual exchange of oxygen and carbon dioxide in the alveoli and in the tissues of the body. So we're talking about in the cells, that's your respiration. When the cell kicks out carbon dioxide and sucks the oxygen out of the bloodstream, that's your respiration. And we use two main things to create energy for our bodies to survive at the cellular level. All right, we use oxygen and we use glucose. Can anybody tell me what does a cell create when it takes those two things? What's the actual energy? I mean, we've all heard, if you remember back to biology in school, your mitochondria and your cell are the powerhouse of the cell and blah, blah, blah. And they make all the energy and everything. What are they actually creating? Anybody know what it's called? Okay. It's called ATP. Kind of lock that one away. You may see that on tests. The chemical that we use for energy, for our metabolism and everything, is ATP. But getting back into this, your body can build all kinds of ATP as long as it's got oxygen and glucose. The as long as that's there, that oxygen, it's called aerobic respiration, right? So, or aerobic metabolism. The cells are able to do stuff with oxygen. And a lot of times, so if we take calories to live, and it may say, let's say it takes like 4 calories to create an ATP with oxygen and glucose. And that ATP will give you, I forget what it is. I forget these numbers, but we'll say 10. You get 10 calories worth of energy out of the ATP you created, and you burn 4 to do it. Now, let's say that something goes wrong and you can't breathe. Your body will switch. It's not just going to stop. All right. So you do have some time if you're hypoxic or whatever, but your body, it knows something is wrong. What it does is it switches to what's called anaerobic metabolism. Remember, we talk about in med terminology, anything that starts with the letter A means without. So without oxygen, you're still metabolizing, your cells are still doing stuff. But to create ATP without oxygen, it's the other way around. It takes like 9 calories to create the ATP, and when the body tries to use it, they're only getting 4 calories out of it. So it's taking more to make less, and that puts you on the negative trend, and then that's when the body starts to kind of wind down. Because without that energy, you're going to pass out, and that's what happens. So first of all, your body gets anxious, and if you don't fix it, then you're going to see your patients start to get drowsy, and then they're going to start to fall asleep on you, and they go unconscious. That's what's happening, is that their body is trying to continue to physiologically just survive, and it can't do it because it's having to burn a lot more calories to create its energy than it is actually getting calories or getting energy from that. All right, so this is basically just a picture showing you how we respirate. This is not ventilation, this is a gas exchange. All right, these are your alveoli in the pictures, in the little boxes. They're covered up by capillaries all around them. And that's where the gas exchange happens. So here's just another picture of you see your blood cells as they're passing around the alveoli. They go from the blue oxygen poor to the red oxygen rich as that gas exchange happens. And these are actually cells in the picture. This isn't the alveoli, but it's the same process. What happens at the alveoli happens at the cells. It's just reversed. So oxygen is coming out of your bloodstream and into the cells rather than out of your alveoli and into the bloodstream. And the same thing with carbon dioxide. They're picking it up rather than dropping it off. Eventually, all cells will die if deprived of oxygen. Here's an example of that, like I was saying. So if you go hypoxic, for whatever reason, you can't get any air into your lungs. For the first minute, cardiac irritability occurs. So your heart rate's going to pick up. 0 to 4 minutes, brain damage is not likely, but your brain is definitely knows something's going on. So you're going to be very anxious. Eventually, you're going to start to feel kind of loopy, like you're drunk. Then you're going to start to feel tired. You're going to notice your higher processes shutting down. Anybody ever been in like an altitude chamber or something of that sort, where they put you in a situation where you can't, like, the air you're breathing just doesn't have as much of a concentration of oxygen to it. Or it could be just if you've been in a high place. People go to Denver, up in the mountains or something. You get altitude sickness. It's kind of the same thing. Your body is not used to breathing like that. Not quite the same. The CBA is still air, but yeah, no, it kind of feels like it, especially when that tank starts to run empty on you. Yeah, 4 to 6 minutes, brain damage is possible. 6 to 10 minutes, brain damage is likely, and then more than that, you're really not coming back from it. So we try to fix hypoxia as quickly as we can. That's why airway is so high up in your assessment. When there is enough oxygen, cells convert glucose into energy through aerobic metabolism. We talked about that. And without adequate oxygen, it's the other way around. The metabolism still takes place, but it's called anaerobic, and it's not enough to maintain. The body will run out of reserves pretty quick if you don't get this fixed. And if you don't get it fixed, then things die. First off, it starts off with cells are dying. Those cells turn necrotic. They start to kill off the other cells who are already weak. Then you wind up with organ failure because the cells are, you're looking at it as a block. The cells die, the tissues die. If the tissues die, then it progresses to organ failure, then system failure, then body failure. And then at that point, you're not coming back. Okay, 648. Keep going. Pathophysiology of respiration. So factors in the nervous system: chemoreceptors monitor levels of oxygen, carbon dioxide, hydrogen ions, and the pH of cerebrospinal fluid and provide feedback to the respiratory centers. Again, they really beat end-tidal CO2 to death at the paramedic level because there's a lot of stuff the paramedics can do with it. And then for a long time, they didn't teach this to EMTs because there's really not a lot that you can do with it. But this is fantastic knowledge. All right. Just because it's out of your scope for you to sit there and finger punch the monitor and everything doesn't mean that you don't necessarily need to know what you're looking at if your paramedic turns it on. Not only that, but knowing how end-tidal works and how the body operates with this means that the basic interventions you do for stroke patients will be better. They have a much better chance of survival. CPR patients, if you understand how end-tidal CO2 works and how the pH scale of the body works, you're going to know much more about whether or not your CPR is effective, because you might be doing all the stuff right according to what the AHA says, and you're going to lose your patient. And it's not necessarily that I'm not going to say that it was your fault, but it's if you had this knowledge and the ability to see what their end-tidal was, you might have known, or you might have been able to pick up on something and say, something's not right. Like, for example, when we're doing chest compressions, we should have at least 10 millimeters of mercury for end-tidal CO2. If it's less than 10, that means your compressions aren't effective. But there's no way of knowing that if you don't know what this is. It's one of my soapbox gripes about how the AHA took that out of their training. That's all over ACLS and the advanced stuff, but these are some things that basics need to know as well. Anyway, I won't rant. So all of these receptors that we are just talking about, these provide feedback to the respiratory centers, and they basically tell your body how fast to breathe or how deep to breathe. Air and blood flow must be directed to the same place at the same time. It's got to work in sync. If something stops one of them, it starts to mess things up. Ventilation and perfusion have to be matched, and under normal circumstances, they are. We just try to keep it that way. If something happens and your airway is blocked, obviously now your blood is still flowing, right? But blood's going to go into your lungs and then back out of your lungs without any oxygen. So now you're getting deoxygenated blood back into the left side of the heart that gets pushed off to the body and it does nothing. So we try to keep everything matched. We try to get your airway open as quickly as we can. And let's say somebody does have a blocked airway. That mismatch starts to mess things up. But as soon as you clear the airway, the body does kind of sink itself back into place as long as it's not so far off that they're already starting to have system failure. A failure to match ventilation and perfusion is the cause of most abnormalities of oxygen and carbon dioxide exchange. And when you can't off-gas the carbon dioxide, it throws your pH out. And again, there's issues with that. That actually does things directly to the size of your blood vessels. It does things to your mental acuity and your level of consciousness, all that stuff. When ventilation is compromised but perfusion continues, blood passes over some alveolar membranes without the gas exchange taking place. So it's pretty much what we were just talking about. Carbon dioxide is not able to diffuse across the membrane into the lungs. Instead, it gets recirculated, which can lead to severe hypoxemia. All right, so hypoxemia, what does that mean? Let's get some med term practice. Anybody? Low oxygen levels signals the brain to breathe. Okay, but the word itself, break the word apart. What does hypoxemia mean? That's what would happen if you had it. But what is hypoxemia itself? There you go. Yeah, low O2. You're right. Megan was more exact on it. It's a low level of oxygen in the blood, specifically the blood. Hypoxia is just low oxygen body wide. Um, Hypoxemia is specific to the blood. All right, factors affecting pulmonary ventilation. Maintaining patient airway is critical. Intrinsic factors that can cause airway obstructions or infections, allergic reactions, unresponsiveness, especially the tongue, right? Like I said, when you have a patient that's completely unresponsive, they lose that muscle tone, their tongue gets in the way, and now you've got a physical barrier stopping airflow from getting into your patient's airway. Extrinsic factors, which means things happening outside the body. You have trauma, which that is the definition of trauma, is anything that happens from outside the body. So it could be a car wreck, um, it could be an injection of something, it could be something you smelled that causes your airway to spasm, that kind of thing. Foreign body airway obstruction, so somebody didn't chew their steak all the way, that could cause it. It's a problem from outside the body. That's your ventilation problems. Problems affecting respiration. External factors such as atmospheric pressure and the partial pressure of oxygen in the ambient environment. So, I use the example of going to Denver. I spent a week in Denver after growing up and living all my life in New Orleans, and the change in humidity, the change in pressure, and everything, being that altitude, it messed with me. I was starting to have some major problems, and wound up with altitude sickness just going to Denver. Um, that happens. I mean, yeah, there's an adjustment to it, obviously, or nobody would live there. But sometimes that transition is not a good one. Internal factors such as conditions that reduce the surface area for gas exchange and consequently decrease the body's oxygen supply. Now we're talking about things inside the body that can cause your respirations to mess up. So pneumonia is a bacterial infection in the lungs. It can cover the alveoli and stop them from getting the gas exchange. Pulmonary edema, which is fluid in the lungs, does the same thing. That happens from CHF. And then COPD and emphysema. The problem with COPD and emphysema is that, like in the pictures you've seen all the alveoli, they look like broccoli, right? The little bulbs are they're very round, and the the capillary bed is wrapped all around each bulb. There's a lot of surface area with that. If you have COPD and emphysema, you start to break off your alveoli, and so the alveoli that you've got have less surface area. Less surface area means less capillary bed being able to pick up the oxygen. So even though you're breathing fine, you aren't getting the same amount of oxygen into the bloodstream and the same amount of carbon dioxide getting out of it. So what that does is that drives up your CO2 levels because you can't blow them out as fast, and your O2 levels drop. So remember we talked about last time how the body actually operates. Our normal breathing is triggered by our carbonic drive. If our CO2 levels climb, our body's like, all right, cool, we got enough acid, let's blow this stuff off, and you pick up your breathing rate. What happens is if your body is just constantly got too much CO2 in it, because for COPD or emphysema, you have less, basically think of like train stations or subway stations. You have less areas for people to switch getting off the subway or getting on the subway. There's just fewer stops. The CO2 just stays high in the body. And it starts to kind of drown out and flood out your receptors that are looking at that. So your body switches to its backup, which is a hypoxic drive. And so instead of saying, all right, we got too much CO2, it says, okay, we don't have very much oxygen. And that's what it tells you to breathe. So it's important that we don't withhold the oxygen from a COPD or an emphysema patient, but make sure you don't flood them with it. It's even more important not to flood them, because not only do we worry about over-oxygenation for the free radicals that can do damage, but we also worry about shutting down their hypoxic drive, because their body is going to say, like, oh, we got all kinds of oxygen, cool, stop breathing. And then respiratory failure happens. Circulatory compromise. Obstructions of blood flow to individual cells and tissues is typically related to trauma emergencies. So pulmonary embolisms, where a clot breaks off and gets stuck in your lungs, stops that the blood flow from getting in and out of the lungs. Simple or tension pneumothorax, that is where you've got air in the chest, air or blood. So simple is air, and then tension pneumo means air and blood. And again, once that's happened, that's where you're losing fluid out of your blood vessels and into the chest cavity. Open pneumothorax, or a sucking chest wound. You see these a lot with stab wounds and gunshot wounds. Hemothorax, which is just blood, and hemopneumothorax, which is blood and air, but they're in the chest cavity, not necessarily the lungs. All right, other causes of circulatory compromise. We have blood loss, anemia, hypovolemic shock, and vasodilatory. We'll just say distributive shock is what I've always called that. So vasodilatory. Basically, it's where your distribution system, your blood vessels, they dilate out to the point where you lose all your blood pressure. So let's talk about these a little bit. Blood loss. Your red blood cells are what carry the oxygen to your cells. So if you have a massive hemorrhage or something of that sort, your patient may be breathing, but there's no more cars on the tracks to bring that oxygen around. Anemia. We talked about sickle cell anemia. That's something that African Americans are pretty common to have, or at least they're more susceptible to have. That's where the normally inflated donut-looking red blood cell is completely shriveled up. And that causes a couple of problems. First of all, it can't hold the oxygen because it's all shriveled up. It's like a popped balloon. The other issue is that they become jagged. And so they have a high risk of clumping together or getting caught on things, and then you have a risk of clots. So anemia is kind of a big deal for a couple of different reasons. Hypovolemic shock, what does hypovolemic mean? We'll start with that. I don't know if people are typing or not. It actually doesn't tell me. Low blood volume, Right. So hypovolemic shock is a direct result of the first thing there, blood loss. Um, that's exactly that. It's just that to a major extent. All right. So losing blood is one thing, but losing so much fluid that you can't, your body's already starting to shut down. That's hypovolemic shock. And then you have your vasodilatory, or just like I said, we always call it distributive. So distributive shock, which is where, for whatever reason, typically it's a traumatic injury to the spinal cord. Is what causes this. Your blood vessels dilate to the point where you don't have any more blood pressure. And with no blood pressure means that when the heart tries to beat, the blood doesn't move. It spurts out into the aorta, and that's it. There's no pressure for the heart to push blood around the system, basically. All right, so 7 o'clock. Take a 10-minute break. Be back 7:10, and we will continue on with the patient assessment. What you got, Donna? Not to my knowledge. I'm not sure. I've never tried it. I would assume no, simply because it's too easy to become test compromised if you printed out the test and then handed it off to people. I'm pretty sure that short of making screenshots, I mean, I tell you, I don't think you guys would do anything, but I don't think there's an easy way to do it. I think the system pretty well keeps it locked down for that reason, because it's like I said, the tests really don't change until a new edition comes out. So if you printed it out and then sent them off, basically, it's too easy for somebody to pass all their tests who didn't really study. It would be. No, I agree. Being able to go back and look at it. I can go in and allow you guys to see your tests at any point. I don't remember if I've got it set to where you can only see it once or not, but I'll go in and double check. And what I can do is I can set it that once you've taken the test, you can go back in and look at it at any time. Um, because I don't really repeat any questions on the module, so I know it won't hurt anything. You can access them after you take them. It's just looking back and forth. Yeah, no, I get it. And I haven't tried it. You may be able to get it to pull up on your phone. I know it works on iPads and stuff like that, but to be able to pull the test up on your phone and then because now it's on a separate device and whatever else you're using. Okay, well, I thought it would be on a separate device. Okay, we're going to get back on it. We'll start off with the patient assessment. So again, now we're going to start building off of what we did with the last chapter. All right. Um, first of all, and whoever wants to answer this when you can unmute to do it, what's the first thing we do on any call? First line of your assessment.
BSI, my scene setting.
BSI scene setting.
Airway.
Not airway. We're not quite there yet. So the very first thing we do is always BSI scene safety. All right. Can't go wrong with that. Just remember when you, like I said, your assessment is a couple of things. A, it helps you remember what all you need to figure out and fix on the call. And B, it gives you a structure that does not change, that no matter what you're looking at, no matter how jacked up that situation might be, you have a starting point, right? And what is that starting point? It's all right, don't forget my gloves, which is, if you're looking at a horror movie scene in front of you, gloves are going to be the last thing you'll forget. But it gives you that starting point. And that's important. The next thing we do is look at what we've got in front of us, right? So we want to figure out, what do we need to fix? How many patients do we have? Do we need any extra help? That kind of thing. And then what help do we need? Once you get through all that, you figured out how many patients you've got. You figured out whether or not you need any extra help, any paramedics or hazmat teams, police, military, prayers, whatever. Now we get to our patient. We're going to get to our patient, look at his level of consciousness, and then we get down to his ABCs. All right, so now we're going to start talking about the A in ABC. So the first thing you need to do is, this is just at a glance, all right? There are no vital signs involved in this. We're not looking for O2 sats or anything of that sort. We're just, are they breathing? It's a yes or no question, all right? There's a couple things that we need to question after that, but the first thing is, are they breathing? Or do they have an airway? If they have an airway, they should hopefully be breathing. If they are breathing, then they definitely have an airway. So your breathing rate is between 12 to 20 a minute, like it says on there, and it should be a regular pattern of inhale and exhale. All right, it could speed up or slow down, but it shouldn't be by much. It should barely be noticeable. If it's really changing gears, that's a problem. All right, we should have bilateral, clear, and equal lung sounds. In other words, you see equal rise and fall of the chest. The left and the right side should rise together. And you shouldn't hear anything like a snore or a gurgle or anything of that sort. It should be nice, clear, easy movement of air. It should be regular. It shouldn't be, in other words, if you're breathing 12 times a minute, yeah, you don't want to hear Strider. If you're breathing, we'll say, 12 times a minute, that's once every 5 seconds. So you should see a breath like clockwork once every 5 seconds, 5 to 6 seconds at the most, as far as the variance goes. And it needs to be adequate depth. Remember, when we talk about vital signs or assessing whether something is good or not, it's not just about the number. Don't get so wrapped. Yes, know the numbers, but also understand that we have to put context to that. Right? Somebody can be breathing 12 to 20 times a minute, but if they're really, really shallow breaths, then that 12 to 20 is not going to count for much, because it's not just how often you breathe, it's how much you breathing per breath. All right, so recognizing some abnormal breathing, if it's fewer than 12 or more than 20. Now, obviously, those numbers aren't set in stone like these slides make it look. So if they're breathing 10 times a minute, that's okay. If they're breathing 8 times a minute, that's still okay, but now I'm really starting to, that's a red flag to me, right? Somebody breathing 8 times a minute, I'm not going to bag them, but I'm going to get the bag ready, or the BVM ready, because if they slow down anymore, they're probably not going to be adequate for life. And then same thing on the upswing of that. Let's say you're at 22, 24 breaths a minute. That's perfectly fine. I don't see any problem with that, especially if they're anxious or had just done something strenuous or whatever. Don't get bent around the axle on the numbers. Again, look at your patient and everything. But if they are breathing too fast, we do the same thing that we do if they're breathing too slow. We bag them, which is going to be fun to see, because usually if your patient's freaking out like that, they're not going to want you to put anything on their face. But what's happening is that they're at risk of blowing off too much carbon dioxide, and then they're going to become alkalotic, which is a problem. So we try to slow their breathing down, not so much to do anything with their oxygenation, but to stop them from off-gassing too much CO2. Your body does need a certain amount of it. You don't want to blow all of it out, because we use that to maintain, like I said, as a buffer. We use that to maintain our pH. Irregular rhythms, which we'll talk about a couple tonight. Diminished, absent, or noisy auscultated breath sound. So if you can't hear it, that's a problem. If you can barely hear it when you know you should be able to hear it better, that's a problem. If it's just not there, or if you hear a whole bunch of accompaniment, like a damn symphony of noises out of the chest, that's a problem. Reduced flow of expired air at the nose and mouth. Again, they should be breathing out very close to the same amount of air that they breathe in. So if they took a good breath, but nothing really came out, that's a problem. Some other issues, you have unequal or inadequate chest expansion. A lot of times you're going to see that in trauma. You have increased effort of breathing, especially the use of accessory muscles. Your accessory muscles really are there as a backup. You shouldn't really see anybody using those under normal circumstances. So if you see nasal flaring, the neck kind of sucking in, that kind of thing, that's a sign that they're having a hard time breathing. And a lot of times that is due to a block in the airway, like a partial block, or a restricted airway where the bronchioles have constricted down, that kind of thing. Shallow depth, talking about how deep you're breathing. Skin that's pale or cyanotic, so blue, cool, moist, cold, and clammy, that kind of thing. Just remember that even though that's the easiest sign to point to say somebody's hypoxic, that's also a late sign. So don't look for that to be your sign that you need to do something. If that's what you're seeing and you haven't made any interventions by that point, your patient at least has been circling the drain for a while. Hopefully, as an EMT, you guys pick up on other things like their anxiety and the way that they're sitting and the fact that they're breathing faster. That those things are your early signs of hypoxia. So focus on those, not on the color of the skin. And then skin pulling in around the ribs or above the clavicles during inspiration. We call that retractions. That's basically the use of the accessory muscles. Sometimes that can be caused by sucking chest wounds or things of the sort, but usually it's just somebody struggling and having to work harder to make their chest expand. The patient may appear to be breathing after the heart is stopped. These are called agonal gasps, or guppy breathing is a term you may hear some people say. First time I saw this, I talked to people about this in CPR classes. The first time I saw it, it looked like the guy was trying to bite the air in front of him, almost like the air was solid and he was trying to take a bite out of it rather than breathe it in. What's happening is that the body has gone into, usually this is caused by cardiac arrest. So without the blood flow and without the breathing, the body has a couple of backups to the life essential processes like breathing and pulse and all that. We have a couple backups so that if the primary fails, we don't just drop out dead. The agonal breath is basically the last ditch effort of the last backup for breathing. So it's not adequate for life. It's just a nervous attempt. Like the last of the workers is like, come on, let's get back going. And, oh crap! All right, we're all dead. So if you see that, don't think that, oh, he's still breathing. Don't let that stop you. All right, at that point, you definitely need to be grabbing the BVM, or the bag, as I call it, and giving them breaths. Another one that you may see is Cheyne-Stokes respirations. These are often seen in patients with stroke or a head injury. So if you look at this picture, anybody that's ever looked at EKGs, this is not torsades. This is breathing. So basically what's happening is as they breathe, they're breathing very fast, and their breaths are getting deeper, 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 and then shallow, shallow, shallow. And then it's almost like they stop breathing, and then they start to kind of come back in, get deeper and deeper and deeper, and then they start to kind of fall back out. There's nothing that you would really see this on, not like a monitor or anything, but that's just a visual representation of what Cheyne-Stokes is. So when somebody's got a head injury, think of it like a car wreck. All right. Sometimes when you wreck a car, the engine will throttle up on its own, and you'll see the RPMs jumping all over the place. That's basically what the body's doing here. Ataxic respirations have an irregular or unidentifiable pattern and may follow serious head injuries. Again, as long as things are working good in the brain, typically our breathing is normal and steady. When you start getting those irregular patterns of breathing, that tells you that you've got something going on, be it like a TBI, which we'll talk about later, way later, but we'll get to that chapter. Could be, increased cranial pressure or intracranial pressure getting high. Sometimes it can be caused by infections, but usually it's just a problem in the brain when this is going on. Patients experiencing metabolic or toxic disorder may display other abnormal respiratory patterns, such as Kussmaul respirations. Kussmaul is actually the one that I've seen the most. When we talk about different respiration problems, Kussmaul respirations are deep, rapid, and commonly seen in patients with metabolic acidosis. So that's why they are deep and rapid. Again, we talk about, this is why I mentioned it earlier, the act of breathing is a buffer for our pH, right? We want to stay in this nice little sweet spot, 7.35 to 7.45 on the pH scale, which is a little bit more acidic than water, or a little bit more alkalitic than water, rather. And the amount of carbon dioxide that's in our body regulates that. The more CO2, the more acidotic we become. If for whatever reason somebody falls into acidosis, be it diabetic ketoacidosis or metabolic acidosis, whatever, when it gets really bad, the body is like, we really need to off gas some of this CO2. So your breathing picks up. First thing that increases the rate. If you still have too much CO2, you still have too much acidosis going on in the body, then your breathing is going to get deeper. You're not going to slow down. You're just going to start really like trying to, you're just blowing it off as fast as you can. That's an automatic response. That's not something that the patient is trying to do. That's just what their body's telling them to do. All right. Patients with inadequate breathing need to be treated immediately. Again, this is A, right? A in the ABC. Actually, there's more B at this point, but this is the very beginning of your assessment. You're not on the circulation yet. We're not onto the secondary assessment, none of that stuff. So if you're seeing these issues, these are the things that we need to fix right off the bat. All right. Don't worry about vital signs. Don't worry about what their O2 sats are or anything like that. We need to fix these issues right now. And you're going to do that with a back valve mask or a pocket mask, depending on what you got, and an O2 cylinder. And then, of course, your airway adjuncts, depending on if your airway is occluded or not. Patients with inadequate breathing need to be treated immediately, like I said, and then move on to the next slide. Assessment of respiration. Even though the patient may be ventilating appropriately, the actual exchange of oxygen and carbon dioxide at the tissue level may still be compromised by several factors, and these are some that we've already talked about. High altitudes, poisonous gases, including carbon monoxide. So remember, think about what carbon monoxide does, right? It gets into your bloodstream. It's everything wants to do the least work in life. I mean, that's not just teenagers, that's everything, even on a cellular level. The path of least resistance is the one that it's going to take. So if a red blood cell is looking at oxygen, which is O2, all right, so two atoms of oxygen bind together, that's what we breathe. Or if it's looking at carbon monoxide, which is only one, it's much smaller, lighter, all right, it can grab it much easier. And because these things kind of work like magnets, it really sucks the carbon monoxide up faster and easier than it does the heavier, more clunky, bulky O2. But that's the problem, is because now that affinity is pulled it in, that red blood cell is tied up. It can't take O2 anymore. And it doesn't, because it's so small, it doesn't exchange right like it would if it had actual O2 in it. So that red blood cell is out for the count for a long time. That's one of the main things that's damaging about CO2, or carbon monoxide, that's a lot of people overlook, is the fact that it's cumulative. All right, so if you walk into a house that's got carbon monoxide and you don't protect your airway, you start breathing that stuff in. Let's say you spend 3 minutes in there, all right, and you make 10% of your red blood cells toxic, and you're like, "Ooh, that's right, this is carbon monoxide, and I'm an idiot for being in here without my SCBA, so I'm going to go outside." and you start breathing fresh air again. Do you lose the 10% of carbon monoxide that you've picked up at that point? Does it reset just by going out into the no, it doesn't. So if you go back in for whatever reason, let's say you don't have SCBA, but you know there's people that's in the house or whatever, so you're like, oh, I gotta get in there and get them, I gotta save them, whatever. You run back in and you're in there for another 3 minutes. You didn't just reset 10% of your blood to being toxic. Now you're at 20%. You stay in there longer than that, it gets even higher. You come out, take some breaths of fresh air, like, okay, should be good. You go back in, now you're at 40%. And it'll get to the point where you start getting sick, throw up, lose you're basically becoming hypoxic, right? So all those same symptoms are going to happen. Eventually, you're just going to pass out and you're not going to wake up. And the scary thing about that is that there's no odor to carbon monoxide. There's no way to know that you're breathing it in until you start to see the signs and symptoms of it. And because the first thing to mess up is your level of consciousness, a lot of times by the time somebody starts to realize that they are in a carbon monoxide setting, their brains are already shutting down to the point where they don't think to get out of it at that point, because they don't, it's like that critical thinking is no longer there. And then they just get tired. And they'll get sick, and somebody might call 911. They might be like, man, I'm throwing up. Everybody in the house is throwing up. But if that doesn't happen, say you're asleep, you just drift off, and that's it. You won't wake back up. So carbon monoxide is a big issue with this. We talk all about the body processes and how we, as EMTs, we want to make sure that they're able to breathe right. But you got to pay attention to their environment too, because just because they can breathe something into their lungs doesn't mean they need to breathe in what's around them. All right, so we just talked about that. This is weird. The slides aren't matching up with my my lesson plan. I'm gonna have to go in and adjust this later on. All right, so opening the airway is what we're at now. Emergency medical care, when you get to A in your primary assessment, that is open the airway. All right, that's what your goal is to do. So that's where you're going to begin when you actually start your patient care, especially if they're unconscious. If they're up talking to you, then their airway is open. That's fine. You can move on. But if they're unconscious, you have to do this. So rapidly assess whether an unconscious patient has a patent airway and a pulse and is breathing adequately. So just do a real quick scan of your patient and look. Be like, all right, do I see any breathing? Airway and breathing are two closely related but separate components. So adequate breathing does not always equal an adequate airway, and vice versa. Actually, I think that's actually written backwards. So just because they have adequate airway does not mean that they're going to have adequate breathing. But if they have adequate breathing, then they must have an adequate airway. Your supine position is the most effective for a patient that is unconscious. All right, it makes it easy for you. Everything lines up. They don't have body weight weighing down on their lungs or anything like that. So if you need to, get them into that position, and they're not going to fall over if they're already laying flat. If you have them sitting up and they're unconscious, it's probably going to be a bad day because they're going to slump down and they're going to lose their airway that way or fall over, and you got other problems. Sometimes the airway must be opened and assessed in the position in which you find the patient, as in the vehicle entrapment. So hopefully they're buckled in or something, and if you need to do them in a seated position like that, you can just lay the seat back a little bit so that they're laying in, gravity's working for you some. A patient found in the prone position, which is what position? If they're laying prone.
On the back. They're laying on their stomach.
There you go, laying on the stomach. Yeah, not the back. That's where you want them. So if they're laying prone, they're laying face down. You must reposition them. All right. Don't do half your assessment and then reposition them. So we're going to log roll the patient as a unit so that the head, neck, and spine all move together, especially in trauma. Which means that if it's you and three of your buddies that are moving this person, you got one person at the head, three people at the body. Who's in charge?
Head count.
Head.
the head. The guy at the head is not a rank thing. It's not an authority thing. It's whoever happens to be at the head. It could be the newest guy. He just started that day. So everybody look to the person at the head, and he may not know. And then you just have to tell him, like, all right, we're going to roll, but we're going to do it on your count. So count to 3, and then we're going to roll. That way they know. And it's because they're the one that's in control of making sure that the neck stays neutral as they make the roll. All right. While care should be taken to avoid injury, remember that airway management almost always takes priority and should not be delayed when caring for patients with life-threatening conditions. In other words, if rolling your patient might harm the patient, but not rolling him means him suffocating and dying, then obviously we're going to roll the patient. We'll just deal with the issues that come with that. Sometimes there's no real easy way to do it. It's like breaking bones in CPR. That just happens sometimes, but it's better to have some broken bones or a little bit of nerve damage than it is just be dead. All right. Other causes of airway obstruction, we have dentures, blood, vomitus, mucus, food, and other foreign objects. It's pretty much anything that can get stuck in the mouth and then swallowed, or not properly swallowed. So when we get to this, if you have an unconscious patient, we're going to have to, first of all, get them on their back, like we said, and then you're going to open the airway. There's 2 ways to do it. One's the head tilt chin lift, and one is the jaw thrust. We use a head tilt chin lift. For most patients, we only use the jaw thrust for patients where we don't know if their neck has been compromised and say like a car accident or something. So if it's traumatic and you suspect a neck injury, then do the jaw thrust. Otherwise, do a head tilt chin lift. And trauma by itself doesn't mean jaw thrust, right? If they took a hit to the hip, the mechanism of injury doesn't appear to include neck damage, then you can do a head tilt chin lift, right? Even if they got smacked in the chest or something, that's fine, as long as it doesn't look like they got whipped around or anything that would have caused any damage to their neck. So the easiest way to do a head tilt chin lift is just put one, like you can see in the picture, one hand on the forehead, 2 fingers under the chin, and you're going to pull the head away from the body. So you're making them look up. You lift up on the chin, push down on the forehead, and rotate it. In adults, go as far as you can. All right. For children, we don't, and we'll talk more about that when we get there, but just go ahead and know that. For an adult, go to the extent of that range of motion. And for children, you're only going to go about halfway. All right, so these just step you through it. And we're going to learn all this stuff in boot camp, so I'm not going to talk about it. We're going to get to skip a lot of the slides in this. The jaw thrust is what we use for traumatic injuries to the cervical spine. So if somebody let's say they were in a car wreck and you suspect whiplash, or they, pop their head on the windshield and that kind of thing, then we worry about the jaw thrust. We don't want to do a head tilt chin lift because we might break their neck. So to do the jaw thrust, you're going to get at the patient's head so that you're inverted. You're going to place 2 fingers, your middle finger and your index finger are going to go underneath their jaw, and then your thumb is going to press on their cheekbones. And then you just basically rotate. You're going to push up with both fingers and push down with your thumbs. So your thumbs are holding leverage against their face, and your 2 fingers, or 4 fingers technically, are pulling up on the jaw. Couple things to note. First of all, this sucks as an airway. All right, it does not really lift that well the tongue, and the jaw is a lot stronger of a muscle than we give it credit for. You think about how hard you can bite down on some things, and we only consciously use a percentage of what our muscle can actually do. You never really consciously use 100% of your force. So if we're doing a jaw thrust, sometimes you really gotta put some elbow grease into it to lift it any meaningful amount. Like I said, even doing it as good as you would like to still doesn't give you much of an airway. All right. And the other thing too is this is a much harder airway to hold open, right? At least in a head tilt chin lift, you can kind of position them where their head's wedged down into the ground or something like that. And then now you've got a pretty easy way to keep their airway open. But with the jaw thrust, you got to really muscle that jaw up, and you can't move your fingers. You move one finger or like one hand, and the jaw is just going to rotate to the side and it's going to collapse back down. So this is one move that you really or can't be expected to do for very long. All right. Once the airway's been opened, look at the chest, and hopefully you're going to see them take breaths. If not, then you're going to have to give it to them. With a complete airway obstruction, there will be no movement of air. All right. So chest wall movement alone does not indicate breathing is adequate. Again, the chest wall by itself is not the big thing. The biggest muscle to control breathing is the diaphragm. If the diaphragm is not moving, be it because the phrenic nerve got severed or something like that, then even though they may be trying to breathe and lifting their chest up, when they lift their chest, it just sucks the diaphragm up with it, and they don't actually create any extra space. So there's no air coming in. Even if the airway is open, the mouth may remain closed. That is one of the issues that you'll see, but that's okay because they can still get air out their nose. So that's just something you'll see. Their lips may not part when you're doing these. This is one of the reasons why this airway kind of sucks, though, it's like I'm saying. So a head tilt chin lift, if you can get away with that, do that one. And then definitely get an airway adjunct in there as best you can. All right, for suctioning, so this is step 2 of A. All right, so we're working on A. We have manually opened the airway. Now we want to make sure that now that we've got the tongue off the back of the throat, we want to make sure there's nothing loose, no fluids, vomit, blood, all that stuff. So if you ever hear me tell you in a scenario or another evaluator that you hear gurgling or something of that sort, you're going to have to suction the airway. That's basically just sucking out whatever fluids, broken teeth, that kind of thing that might be in there. Gurgling is the key word for that when you're in an evaluation. So listen for that. Otherwise, I mean, if I tell you the alternative to that is I'll tell you that the airway sounds clear, you don't hear any gurgling. That just means you don't have to suction, so you can move on. We will go over suctioning equipment at the boot camp. There's really not a way to do that in this particular lesson because we're all virtual. And not only that, but there's a bunch of different suction units out there. Some of them are handheld pumps, some of them are automatic, some of them are electric or whatever. So, even if I had one that I could turn my webcam on and show you right here, it may not be what you use. I want to get you guys to kind of see things that you use at your departments. And so when we get to the boot camp, we'll have a couple different units, and it'll just be better. So techniques for suctioning, there's a little bit to this. All right. So first of all, you want to inspect your equipment regularly. We usually do that every day on a truck. So to operate the suction unit, you check the unit for proper assembly, make sure everything is there. It has to be a complete unit. You can't be missing anything. You can't have any open plugs or anything like that because, again, path of least resistance. If you have a leak in it, it's going to just pull air in from that leak rather than sucking up whatever weighted vomit or teeth or whatever you're trying to get out of your patient. We always test our unit with an emergency suction range, which is 300 millimeters of mercury. So you basically crank the dial up to the point where you see 300 whenever you activate the suction. If you set it to where it should be at 300 and you activate suction and it only suctions at say 150, then that means your unit's not good and you need to either swap it out or figure out if you've got a hole in the system, something like that, that's stopping it from creating the suction that you need. All right. So when you suction, let's say that you have a patient and tell you that your patient is gurgling. So now you know that you need to suction. You never suction the mouth and nose for more than 15 seconds at a time. I usually just say 10. 10 is an easy number to remember because it's 10 to 15 for an adult, 5 to 10 for infants and children. So just go with 10. That's your magic number. All right. Suctioning can result in hypoxia because, again, you're pulling air out of them as well. It will also cause their heart rate to dip. There's another reason why we don't want to do it for more than 10 seconds. Whenever you do suction out something, especially if you're suctioning out either thick mucus or teeth, that kind of thing, whenever you get done suctioning a patient for X amount of time, suction some clear water just to kind of clear the tube out. Because if it gets clogged up, now you no longer have a suction. If your patient starts to gurgle again or something gets into their airway that wasn't there before, you have no more suction to clear it. So we suction for no more than 10 seconds, and you suction by putting the catheter as deep as you want to go. Obviously, you don't want to hit the gag reflex if you can help it, but go to the back of the mouth and then suction on the way out. So I'll show you how to do it when we get to the boot camp. But essentially, when you go to do a suction, there's a hole on the handle of the catheter. As long as you don't cover up that hole, it's not going to suction anything out of the tip. The suction is going to pull air in from that hole, so you can actually put the tube into somebody's mouth. It's not going to start suctioning immediately, whatever. But when you plug that hole with your finger, now the next hole for it to pull from is at the tip of that suction unit, or we call them yankers. And so now you're suctioning, but you're suctioning from the back of the mouth, which is what you want. And then you hold the suction as you withdraw so that you're suctioning again on the way out. The NREMT, and I want you to know the 10-second rule because that's what they're going to ask you on the registry. All right, real world, and even what is taught in PHTLS and other trainings that happen after this class, it's you suction until the airway is clear. Because if you stop at 10 seconds, they still got shit in the airway. What good did the suction do, right? But for the test, 10 seconds. That's your max, and no more than 10 seconds. All right, that's a foot stomp because that's some disagreeing information that you may hear. Just know that the registry still sticks to the 10-second rule, and they do that because the longer you suction, the more you're going to drop somebody's heart rate. And especially that's why like kids get the least amount of suction, is because remember when you talk about CPR, if a child or an infant has a pulse less than 60, they may as well not have it. You're still going to do compressions. So it's much more critical for them. So 10-second rule. All right. Just like CPR, everything, if they ever ask you how long something is, always 10 seconds. All right. If the patient has secretions or vomitus you can't suction out easily, then just remove it, roll them over onto their side. We put them in this is called the recovery position or left lateral recumbent. If we put them on the left, if we put them on the right, it's called right lateral recumbent. When you roll them on their side, basically what you're doing is you're allowing gravity to pull their pull the fluid out of their mouth, and then you can actually try to sweep it with your finger as well. This is mainly for things like if there's large chunks that they can't get into the suction. This is an easy way to get out big things, like if they threw up stomach contents, teeth. Sometimes teeth are going to be too big to fit into the suction. So if you every time you go into the mouth to suction out something, you keep getting clogged up on something big. This is what you're going to do: pull out the suction, roll them on their side, use your finger, sweep out all the junk that you can get, and then try to suction again. If a patient who required assisted ventilations produces frothy secretions as quickly as you can suction them, suction your airway for a little bit longer, 15 seconds, but I mean, you can still pretty much stick to the 10-second rule. Then you're going to vent for 2 minutes, which is how do we vent? If you ever hear ventilate the patient, what are you doing?
Breathing for them.
Breathing for them. So how are we going to do that? There you go, the BVM, right? Bag valve mask. So after the 2 minutes, suction them again, and then go back to ventilations. Continue this alternating pattern of suctioning and ventilating until all secretions have been cleared from the airway. Hopefully, you can do that. Sometimes people have a bleed, or if it's a burn victim, they're going to have fluid that's just kind of dumping into their airway if they've breathed in superheated gases. So you may have to put somebody on suction duty, and for the entire call, they're just suctioning the patient. Continuous ventilation is not appropriate if vomitus or other particles are present in the airway. It doesn't really do you any good if you can't get the air into their lungs. So once you're done, clean and decontaminate your suction equipment. I'll say this too. Whenever you suction, it all winds up in a container. Keep that with your patient. All right. When you get to the ER, bring it in. It's not so much that you're making it their problem to throw away. It's just that the nurses are going to be wanting to track IO, which is input and output, right? How much did the patient take in? How much are they are losing? That all plays into their hydration. And also they want to see what they're throwing up. It could be because there may be medicine or pills or who knows what's in there. So bring that with you to the hospital. All right. Once you have cleared the airway of any junk that might be in it, like I said, we can't hold a jaw thrust forever. And besides, you can't do any other assessment if you can't move your hands off of your patient's face. So now we need to put something there that will maintain that airway once you let it go. All right. That's where we get the basic adjuncts, and we have two of them. So an airway adjunct prevents obstruction of the upper airway by the tongue. That's what we're mainly trying to do, is keep the tongue off the back of the airway. We have OPAs, oropharyngeal airways, and NPAs. The OPA keeps the tongue from blocking the upper airway, and it goes in through the mouth. They're pieces of plastic, and they're designed in a way that they have a mouth guard where they butt up against the front of your teeth, and they kind of hold themselves in place there. And they've got a curvature that goes up and over the back of your tongue and holds it there. Sorry, getting a couple texts. The only problem with the OPA is that it has a really big chance to cause them to gag. Hold on. So if they're pregnant, left lateral recumbent, well, yeah, if you can help it, because you don't want to put them on their back. Which again, like I said, we'll get to that when we get to pregnancy. But it doesn't necessarily have to be left. You can put them on the right side. You just want to get them off of their. You don't want them completely supine. An unconscious pregnant woman, even if you need her to be supine to get your job done, what we have done is we've put them on a board, a long board, and then we stick something underneath one side of it, so they're not really all the way on their left or their right, but they're turned so that the weight of the baby is not sitting directly on their vena cava. It just depends on what you need. If you're fighting suction and clearing the airway, then yeah, you may need to put them all the way on their side. All right, Dwayne. The OPAs are designed also, they're hollow. They look like IVs. The reason that is the way that it is so that if you have to suction them with the OPA in place, you can use what's called a soft suction, which is just a tube. All right, it operates the same, but it's a flexible tube, and you can run it down the center of the OPA, and because it's the way that it's shaped, you're able to get it around, say like any junk or whatever. It just kind of flows around the curvature of it down to the back of the tongue, and then you just suction on the way back out, just like you normally would. All right. So if you need to use an OPA, we have, or any kind of intervention, be it, learn these two terms. I'll just say that now. Indications and contraindications. Indications are the reasons to do something. Contraindications are the reasons not to do something. All right. So an indication for nitro, for example, would be a heart attack or chest pain related to heart problems. A contraindication for nitro would be blood pressure under 100, because if you give it to somebody with low blood pressure, they're going to bottom out, and then you're going to be doing CPR. So that's an example of these. Now, when it comes to the OPA, your indication is an unresponsive patient without a gag reflex. The only problem is there's only one way to find out if they got a gag reflex, and that's to try the OPA. So when you're dealing with a patient like this, the OPA is definitely better than the NPA. So what you're going to wind up doing is put the OPA in their mouth and then see if they take it. If they start gagging and choking, then obviously pull the OPA out, and we're going to switch to the NPA, which is the nose. Apneic patients being ventilated by a BVM can definitely use a OPA if you can put it in there, because that is fantastic. When you're breathing positive pressure for your patient, you're forcing air in. You have a very high possibility that airflow is going to push the tongue back. So having an OPA there makes it easier to keep that from happening as the air is flowing through. Contraindications or conscious patients, I don't care how bad you are. You probably, I don't want to say that. You're probably not going to take an OPA if you're conscious, but there's some people that can. Any patient that's conscious or unconscious who still has an intact gag reflex. Again, you might be unconscious in that you can't respond to the world around you, but you're not so unconscious that your reflexes are gone. So you'll have patients that are like that, where they're unconscious to your AVPU basically, but they still have reflexes. You put it in, they'll gag on it. The gag reflex is a protective reflex that keeps food from entering the airway. Because remember, your airway is what's open by default. So if something were to fly into your throat without you swallowing first, um, the route that it's going to go is your airway. So your gag reflex is there to push it back before that happens. An oral airway is a good way to help maintain the airway of a spinal injury patient because it goes in through the mouth. All right, there's an actual physical gap between where the airway is in the mouth and where the base of the skull is for the brain cavity. Oral airways may make the head tilt, chin lift, jaw, and jaw thrust maneuvers easier to perform. And once you put those airways in, you really don't have to do those head maneuvers anymore. You can take your hands off, at least from that. You may still have to have somebody hold their C-spine, but they don't have to bother with the head tilt or hold the jaw up and all that stuff. And an oral airway that is too large can push the tongue back into the pharynx, blocking the airway. There is a way to measure it. Basically, you take the airway, you put the teeth guard up against the front of the teeth, and you should have the airway extend to the side of the jaw where it angles up toward the ear. Again, we'll go over that when we get to the boot camp and let you guys get plenty of practice with it, but that's how you're going to do it. You're going to always measure your airways before you put them in. If you do encounter difficulty inserting the oral airway, an alternative method can be used. And again, we'll show you that as well. There's like three different ways to put them in based on the structure of the mouth, or especially if it's a person with head trauma where they got popped in the face and their mouth is no longer normal because of the damage done to it. There's other ways to do it. So nasopharyngeal airways, again, I don't like these as much as OPAs. They're just not as good, but a lot of times this is what you have to use. So indications for this one: your patient is unresponsive, so they can't maintain their own airway, or they have an altered level of consciousness. If they do have a gag reflex and can't take the OPA, then we pull that out, we put this in. Your patient is unable to maintain his or her own airway spontaneously, usually because they're either unconscious or because there's some kind of toxic issue going on or something that's making them too drowsy to maintain it on their own. Patients with an altered mental status or who have just had a seizure may benefit with this, all right, because they're going to still probably have a gag reflex, but you need to get their airway to stay open. Consult med control before inserting a nasopharyngeal airway in a patient who has sustained severe trauma to the head or face. Remember when we looked at chapter 6 at the skull, and we talked about the cribriform, not the cribriform plate. Yeah, the cribriform plate, the base of the skull underneath the brain. It's above the nasal cavity, and it's what separates the brain cavity from your pharynx. But the only thing about it is it's paper thin. Usually we don't get hit in a way that can break that, but if you get smashed in the face bad enough, it can break. And there are patients that are still wide awake with facial trauma like that, so you can't give them an OPA, and you have to use an NPA. But the problem is that the NPA may go through and into the brain, and you may poke the brain. So for a long time, they said just don't do it. But research showed that even though it was possible, the odds were still pretty low. That being said, I personally don't want that decision on me. I don't want to be the guy that said, yeah, I'll put an NPA in and then stab somebody in the brainstem. That's usually not how you want your patient to die on you. So, call med control. When in doubt, call med control. It's okay to, even if you know what you need to do, if you're like, I know that this is what I need to do, but I don't want to make the decision on my own, call med control and just say, hey, got this patient, these vitals, want to do this. What do you think? And the doctor will say, yeah or no, and then they'll hang up on you. But because like I said, they're working in an ER too. But yeah, it may penetrate the brain, so be careful with that. It's the only real concern about an NPA. NPA is just a rubber tube. So an NPA is usually better tolerated by patients who have an intact gag reflex. In fact, in the military, we used to mess with each other in our training, and we would give each other an NPA just because we're dumb, and why not? Um, less likely to cause vomiting compared to the the OPA because you're not messing with somebody's gag reflex. Again, indications: semi-conscious or unconscious patients with a gag reflex, patients with otherwise who would not tolerate the OPA are going to get this. Your contraindications: severe head injury with blood draining from the nose. And when we get to trauma, we're going to talk about CSF and how you can detect whether that's mixed in the blood or coming out of somebody's head. And if it is, that means there is a crack somewhere in the skull that you can't see, and that fluid from around the brain is leaking out. So if you see CSF, that's a big red flag about maybe I shouldn't use this airway again. But call med control, because depending on just because it's there doesn't mean that crack is anywhere near where the OPA or the NPA is going to go. And again, we'll talk about how to put the NPA in when we get to the boot camp. So maintaining your airway, we're gonna get through this part. When we get to oxygen, we'll take our next break. The recovery position is used to help maintain a clear airway in an unconscious patient who is not injured and is breathing fine. That's the trick to this, all right? If they still need you to bag them, you can't do this. It's not gonna work right. But if they're breathing on their own, say they're in a diabetic coma, something medical, or they, it may be an overdose patient or a exceptionally drunk patient, somebody that's already on the verge of blacking out, but they're not to the point of like respiratory failure. You put them into what's called the left lateral recumbent. That's what you see on the slide. So it's their left side with the bottom hand is going to be, this one's done a little bit differently. What we usually do is we'll take their their left hand, and we'll extend the arm up overhead so that when we roll them onto that side, they're laying on their arm. It keeps their head and neck in line. And if anything, it allows their face to kind of angle down toward the ground a little bit. So if they vomit, it just runs out the mouth. And that's perfectly, unless there's, like I said, unless there's some kind of trauma or something that doesn't allow you to do this, or if they're not breathing well and you have to bag them, you can put them into this position and it helps maintain the airway. If this is a patient that you just got back from CPR, so you actually managed to get ROSC, which, kudos to you, because that's not easy to do. You can put them into this position because as they start to come out of it, as their body starts to return to normal function, they're probably going to throw up on you. This is a good way to not have that happen, and it keeps their airway clear. All right, but again, if there's trauma to the spine, hip, pelvic injuries, neck injuries, any of that kind of stuff, you want to keep them on their back. Don't roll them over. We'll talk about how to roll patients when we get to the boot camp. All right, good timing. Take another 10-minute break. We'll be back at 8:10 or 8:08 rather, and we'll get started with supplemental oxygen. Donna, is that you've had 2 NPAs put in? NPA won't go as far as the COVID test. I will. I've had nose swabs done to me before. Those things like poking your brain. Course has 7 NPAs put in. Yeah, no, I'm lucky. I'm not the lowest ranking guy in the tent anymore, so now I'm not the one playing patient, getting the NPA and the NG tube and all that stuff. That's miserable. Oh, 7 COVID tests. Yeah, yeah. No, we just like messing with each other. See who's ballsy enough to take an NPA. Usually, it's the lowest guy because he gets voluntold. Anyway, I'm going to take a break too, so I'll be back in a few minutes, and then we'll continue on with oxygen. Okay, it's been 10 minutes. So we need to get back on it, get to the supplemental oxygen. This is the part where we start getting a little bit more technical about things that are not so, because we're going to talk about like the size of the oxygen cylinders and stuff like that. So we kind of change lanes here. A lot of this is direct patient care and how you are going to give oxygen and when and why, all that good stuff. But we're also going to talk about the cylinders, which is that's what most people get hung up on. So when we talk about people struggling with airway, it's when we start talking about things that don't really equate to actual patient care. So bear with me as we get through this, and then we'll get through the night. All right. So supplemental oxygen. This is one of the things that we pick on each other about. Almost every EMT is like, man, I am a master at giving oxygen, and we used to give it to everybody, but like I said, now there's a little bit more of an art to it. We're not just going to pump somebody full of 15 liters, not a breather, because they stubbed their toe. Always give supplemental oxygen to patients who are hypoxic because not enough oxygen is being supplied to the tissues and cells of the body. But we do want to keep it within that 94 to 99% range. Some tissues and organs, such as the heart, the central nervous system, the lungs, kidney, liver, need a constant supply of oxygen to function normally. Some can go a long time, right? The GI system, for example, your digestive tract can go a long time without oxygen. It's actually one of the last things to have problems to have problems just in that's clean. Never withhold oxygen from any patient who might benefit from it, especially if you must assist with ventilations. That includes your COPD patients. Um, just know that if the danger of not giving it to them is worse or perceivably worse than giving it to them, then just go ahead and do it. When ventilating any patient on cardiac or respiratory arrest, use high concentrated supplemental oxygen and don't even worry about their O2 sats at that point. The 100% rule goes out the window for a couple of exceptions. And if you're doing CPR, that's one of them. All right. Stroke patient, that's another one. So let's talk about some equipment. First of all, you have to know how we're going to get the oxygen to the patient. All right. And some of the hazards that you may deal with it. So let's talk about the cylinders, oxygen cylinders. Oxygen that you will give to a patient usually is supplied in a compressed gas in a green cylinder. All right. There are other colors out there like yellow. Yellow is air. All right. It's not bad, but you're not giving your patient 100% oxygen. That is a color code. Anytime you see green, if you see a green label, it's for oxygen. If you see a green cylinder, that is an O2 tank. Now, they're not always solid green, right? Some of them are going to have like the actual barrel portion of it is going to be brushed steel or something. It'll be clear, or not clear, but it'll be shiny silver, and you can kind of see yourself in it or whatever. And then you've got a green cap and a green base, but green will be on there, and it's not mistakable. Anything that you connect to in a hospital, if you're in the back of an ambulance and you see the little oxygen connectors on the wall, the oxygen is green. All right, so look for a green knob or something like that. If you go into a nursing home for somebody that is not feeling well or whatever, and you're going to use their equipment instead of your bottle to give them oxygen, make sure that you actually plug everything up to the green connector on the wall and not the yellow one sitting next to it. I've seen that messed up too many times. Some cylinders may be silver or chrome with the green area around the valve stem. I just mentioned that. Newer cylinders are often made of aluminum or spun steel. Old cylinders are much heavier. Any firefighter that's been in the service for a long time, you remember those old steel yellow SCBAs that weighed like 50 pounds, that versus the carbon fiber ones that we have now or whatever that's much lighter. Check. All right. So if you are going to mess with the cylinder, the first thing you want to do is check that the cylinder is labeled for medical oxygen. Again, green is your go-to color. Look for letters and numbers stamped into the metal on the collar of the cylinder. Check the month and year stamps indicating when the cylinder was last tested. So you don't have to know this like by the numbers, but just understand that aluminum cylinders are tested every 5 years. Composite cylinders are tested every 3 years. They're talking about hydro testing. So that's not something that we do. Typically, your agency will send them off and get them tested, and they'll come back with a new stamp on it. We do the same thing for other things. We our SCBA bottles in the fire department. The what am I thinking here? Fire extinguishers, anything compressed like that, they get sent off to be tested just to make sure that the valve stem and everything is still holding up well. So most often the D or jumbo D and M cylinder sizes will be used. The average bottle that you see, the one like the medic carrying it in or the EMT carrying it in, and you're going to hook it up by the patient's side, that's a D cylinder. The jumbo D is usually just longer, and then you have your M cylinder as well. It's not that I haven't really messed with M cylinders too much, but you see those. These can be carried from the unit to the patient. The M tank remains on board the unit as a main supply tank. These are huge. These are the ones, if you see like trucks going down the road with a whole bunch of them stuck up on a flatbed truck, that's what the M cylinders are. Most of your ambulances that have O2 lines running in the walls will have an M tank like in a cabinet in the corner. Other sizes you may see, not necessarily common, but you may see them out there. You have the size A, E, G, H, and K. Again, like I said, I don't want you guys to think that you have to know all of them. Just know the D. All right, know the D size cylinder or the jumbo D. They're the ones that you're going to have. You'll see them strapped to the cots, carried in. Sometimes they're a lot of medical bags that you can put a cylinder in are designed to hold a D cylinder. And an alternative naming system for identifying the size of the oxygen cylinders are labeled with M for medical, followed by a number. So you may see, instead of seeing all the different letters, you may just see the letter M with a number after it. The length of time you can use an oxygen cylinder depends on the pressure in the cylinder and the flow rate. So obviously, if you're going to crank every patient to 15 liters, you're going to run out pretty quick. Thankfully, we don't do that anymore, at least not to that extent. So we're not burning through 2 or 3 bottles a day. All right. As you can, okay, here we go. Liquid oxygen is becoming a more commonly used alternative. Those don't really come in cylinders like what we're used to seeing. We use liquid oxygen on the planes when I was a flight medic, and what it was just a box with some tubes inside of it with some liquid oxygen, and it was highly compressed. But let's see if I can remember this. 1 liter of liquid oxygen came out to something like 804 milliliters once it turned into a gas. So as you can see, like it takes very little oxygen, very little liquid oxygen to make almost an endless supply of actual breathing oxygen when it finally gets to the patient. Usually your cylinders contain compressed gas, so they don't have the cylinder by itself doesn't have the means of converting that liquid into a gas. Some safety considerations: handle gas cylinders carefully because their contents are under pressure, right? Anytime, especially at boot camp, and I want to build this habit into you guys the whole time, it's very easy to stand those tanks up. All right. But when you're not directly messing with them, if you don't have at least one hand on them, lay them down. Because if they fall and the stem breaks, they become a missile, and who knows what direction it's going to go in. Make sure the correct pressure regulator is firmly attached before transporting cylinders, and it is okay. In fact, I do it all the time. Once you have the regulator in place, you can use that to carry the cylinder, unless it's some massively big one that's just too heavy for the regulator. A puncture or a hole in the tank can turn it into a deadly missile. Secure the cylinders with mounting brackets when they're stored on the ambulance, especially those big M cylinders. They weigh as much as I do. So, we usually have like special lifting tools built into the ambulance to pick them up, that kind of thing. You don't want those falling over. Oxygen cylinders that are in use during transport should be positioned correctly and secured. A lot of your stretchers now have a strap system built in right behind the head of the patient for you to slide the cylinder into, the normal portable one. And that way it stays right there and it's close to the patient's head, so your tubing isn't stretched out for you to get caught on or anything. All right, so your pin indexing system, This prevents such mistakes as an oxygen regulator being accidentally connected to a carbon dioxide cylinder. You don't want to you really don't want to do that to your patient. Basically, what it is on the inside of the so on the stem of each bottle, there's two little holes. At least there's two holes side by side on an oxygen cylinder. Some cylinders may have more holes, or the holes may be in a different configuration and that kind of thing. The regulators that we put on there, we have to line up. There's two pins, obviously. So, like I said, if there's two holes on the O2 tank, then you have to have the two pins that are built into the regulator that has to line up. If you're trying to put a regulator and those pins don't line up, you're probably using the wrong tank. All right. Each cylinder of a specific gas type has a given pattern and a given number of pins following accepted national standards. Again, so your regulator is meant to fit an O2 tank. If it doesn't fit, you're not playing with an O2 tank. For large cylinders, the safety system is the American Standard Safety System. Gee whiz. Oxygen cylinders are equipped with threaded gas outlet valves. And like I said, when we get to the boot camp, we're going to show you how to hook up all this. This is actually one of your individual skills for the registry, is how to hook up oxygen and deliver it. So we'll go over this on one of the first days, if not the first day, so that when we get to your scenarios, you're going to already have this information down. You're going to know how to hook it all up. You'll be able to do it in your sleep. In fact, a lot of you probably already can. They're not hard. There's a set order to it so that you don't blast all the air out of the tank. That's all. Inside and outside thread sizes vary depending on the gas in the cylinder. And like the pin indexing system, this prevents accidental attachment of a regulator to a raw cylinder. So with the pressure regulators, the pressure regulator reduces the cylinder's pressure to useful therapeutic range for the patient, usually around 40 to 70 psi. You got to think, those cylinders themselves are high pressure, right? You crack them and they're just everywhere. Like they'll blow off real fast, so fast that they can freeze the stem as they're coming out because of the pressure and everything. So that's not how we want to give oxygen to our patient. We don't want to see their nostrils flaring up like parachutes or anything like that. After the pressure is reduced to a workable level, the final attachment for delivery of the gas is one of the following. We either use a quick connect female fitting that will accept a quick connect male plug from a pressure hose or a vent resuscitator. A lot of times we see that in the way we connect our sorry, I'm drawing blanks here, non-rebreathers or nasal cannulas. Or you can have a flow meter that will permit the regulated release of gas measured in liters per minute. So you can have, a lot of times that's what we use. So we can set it to, if we want 15 liters per minute, 6 liters per minute, 2 liters per minute, whatever we want to give. All right, for your flow meters, these are usually permanently attached to the pressure regulators on emergency medical equipment. They're usually a one-piece thing. When you put it on the cylinder itself, that's everything you've got. The flow meter is attached to it. A pressure compensated flow meter incorporates a float ball within a tapered calibrated tube. A lot of times you'll see those on the walls of ambulances or sometimes the walls of like a hospital room or something. And this is affected by gravity and must always be upright if you want, because that all it is as you're opening it, there's a little ball bearing that's in there that will go up as you increase the flow. If you put this thing in upside down, obviously it's not going to work right because gravity's going to just pull the ball down, and then you have no idea what you're setting your flow at. The Bourbon gauge flow meter is a gauge calibrated to record flow rate. It's going to be used in any position and is generally considered outdated. We really don't see those anymore. All right, so your hazards of supplemental oxygen, combustion, right? Oxygen is highly combustible. There's some things it doesn't play well with, like fire, for one thing. Oil is another thing. We really don't want to have 100% oxygen sitting around oily rags or, really just that, oily rags or any other kind of oil source that's right next to the oxygen. Oxygen speeds up the combustion process. That a lot of that's self-explanatory. As firefighters, we get this beat into us about how the fire triangle and tetrahedron works and all that. this is usually 100% oxygen. So if you get this near a flame, that flame is going to get real happy real quick. Keep any sources of fire away. Make sure the area is adequately ventilated so that you can dissipate it as it grows and gets into the air around it. Never leave an oxygen cylinder standing unattended. Again, we're gonna harp on you guys at the boot camp. The minute you take your hand off of that cylinder, the last thing you should be doing with it is laying it down. Don't leave it standing up, especially once you're hooked up like a non-rebreather to it or whatever, and you're fumbling around with it, because if you pull too hard, you pull it down, you can break the regulator off of it. And now you've got a missile shooting off across the room. Oxygen toxicity. The administration of oxygen to patients is a common practice. We used to give everybody oxygen. You couldn't go wrong with it. In fact, if you look at your assessment, it still says it's a critical fail if you don't give oxygen to your patient. That being said, I want you guys to at least tell me that you're going to consider giving high flow O2. I don't want you to get into the habit of just doing it, but I want you to know that that is a critical fail. You do have to at least mention oxygen. Whether or not you're going to give it, you can say I would consider it, but I'm not going to do it. That's enough to satisfy the critical fail. Anyway, so while many patients in the pre-hospital environment require high concentrations of oxygen, not all patients do. Excessive supplemental oxygen can have a detrimental effect on patients with certain illnesses like COPD, because we talked about that, how it dumbs out their urge to breathe. The other issue, and I'm going to kind of skip over the bulk block of writing in my lesson plan on this, is that if you give a patient more than what's considered 100% O2, all the unused oxygen breaks off into free radicals. So remember, O2 is exactly that. It's two atoms of oxygen put together. That's what we breathe. If we don't hold that properly in our cells, if we give too much, all the excess breaks off into oxides, monoxides at that single. It's no longer O2, it's O1. And those things are not bound to anything. They will fly through your body, and they're like wrecking balls. Every cell they run into, they just pop it. They'll destroy whatever cells, and these things are bouncing all through you. The more excess oxygen you give, the more these things you have going around in you. It got pretty bad there for a while because, like I said, we give everybody 15 liters non-rebreather, and now it's like, oh, whatever. You were at 100% before we even started. You're really rocking it now. No, we were really just killing our patients. Yeah, I know. What a tragedy could have been avoided. No, whoa, wait a minute. I missed some of this. So people don't understand the dangers of smoking while on oxygen. Yeah, that happens. We have people that, just in my town, we got people that are on home oxygen systems, and they smoke like a chimney while they're on the oxygen. Had a lady that blew up and ended up dying. Wow. Okay, oxygen delivery equipment. In general, oxygen delivery equipment used in the field should be limited to non-rebreather masks, or what we call NRB, BVMs, and nasal cannulas. Now, these are the three things that you're going to use. And I'm going to kind of explain, this is a decision-making process for you as an EMT. If you show up to a call and you've got a patient, you get to Airway, the Airway is, you've made it patent or whatever, now you have a decision. You have to look at them and say, are they breathing adequately or are they not breathing adequately? If they're breathing good, then you can give them oxygen if they need it using either a non-rebreather mask or a nasal cannula. All right, that means you don't have to breathe for them. They're doing fine on their own. You just want to up their O2 set a little bit. Those are the options that you've got. You'll use one or the other. If they're not breathing well, that means you have to breathe for them. So you're going to use the bag valve mask. You can't use a BVM and an NRB at the same time. You're going to be competing for real estate with one mask versus another. You can, however, use a nasal cannula and any of the other ones. You just need a oxygen source for each tube. It's the only thing. There are times where you want to hyperoxygenate people, even if just for a little bit. Paramedics typically will tell you when that's something that they want to do. A lot of times it's leading up to them putting in an NPA, or I'm sorry, an NPA, an ET tube where they're going to put an advanced airway in. They may hyperoxygenate the patients. They may hyperoxygenate a patient that's having a stroke or just going into shock, that kind of thing. because they're trying to fight the effects of that shock. But as a basic by yourself, usually just one or the other is fine. But like I said, when you're going through your assessment, and you get to airway, you're like, okay, is the airway open? No, I'm going to do a head tilt chin lift. Now it's open. I let go of it. I just lost it. I need to put something in there. I put an OPA in. Now I can let go of my head tilt chin lift because I have a patent airway. I'm going to move on to breathing. Is he breathing adequately? No, he's not. Okay, I need the bag valve mask. I'm going to give him breaths with the bag valve mask. Is he breathing adequately? Yes, he is. Great. Don't need the BVM. Going to use the NRB or the nasal cannula, depending on what range of oxygen I want to give. So let's talk a little bit about each one. Are you learning your mom's? Okay, you're learning so much from here or from your mom or both? That'd be great because she probably knows a lot about her condition. So okay, it's well, kind of. So oxygen is not the vasoconstrictor. CO2. No, wait, I'm backwards. You're right. Oxygen is the CO2 is the vasodilator. Um, what we do for that, what you're talking about, Jim, is if we increase somebody's breathing, it's not the increase in oxygen that constricts their blood vessels, it's the decrease in CO2. I mean about the oxygen toxicity. Oh, yeah. Yeah. Vasoconstriction, Jim, for yours is actually it's a drop in CO2 that causes that. It's not necessarily the oxygen, but you're on the right track. That's why, like, if you probably worked a stroke patient where they wanted you to hyperventilate the patient, what they were doing was they were blowing off his CO2, getting his pH down to a certain point that would have constricted the blood vessel so that he didn't. If your stroke patient is having a hemorrhagic stroke where they're bleeding out into the brain, it stops them from doing that. But that's you kind of ride a line with that. If you do it too much, they don't get any blood flow to the brain at all. It just makes the stroke worse. But if they're bleeding out, that helps control it. Non-rebreathing masks. The preferred way to give oxygen in a pre-hospital setting to patients who are breathing good, right? So you don't have to bag them, but are suspected of having or showing signs of hypoxia. If you can actually see that they need oxygen, give them the non-rebreather. When you get to the point of checking their vital signs and you look at their vitals, they're rocking 100% O2. Yeah, you can dial it back. You can dial it back a little bit. There's a range of oxygen we're going to talk about for this. If you have to dial it back further than that, then you can switch to a cannula, which is meant for low flow. What this is you have a mask here, and they breathe through the reservoir bag. So they call it a non-rebreather because the O2 tube fills the bag that you can see in the picture. When they take a breath, they're breathing it from the bag. When they breathe out, the valve, there's a series of one-way valves in there. When they breathe out, the valve that feeds oxygen from the reservoir shuts so that they're not breathing CO2 back into the bag. And then there's two valves on the top sides of the face mask that pop open, and that's where their exhale goes. So then the next time they breathe in, those two valves on the top left and top right close down, and then the valve above the reservoir bag opens up, and then they get another breath of fresh oxygen. That's a great way to get somebody's O2 sats up. But again, that's a high flow thing. So if you're only talking about a small range, this may not be the option for you. The other thing too, sometimes your patients don't like having things on their face, so they may not tolerate. They may like swat at it or try to pull it off or whatever. In which case, you can always switch to the cannula. Make sure the reservoir bag is full on these because that's where they're going to get their oxygen from. Adjust the flow rate so the bag does not collapse when the patient inhales. We usually do 10 to 15 liters a minute. If you're going to be under 10, then you should probably switch down to a cannula. If the bag does collapse, increase the flow rate. All right, especially if you've got somebody that's doing a lot of deep breathing, they may be sucking that bag dry before it can fill up. And it is important that this bag is full. We'll show you how to inflate the bag initially when you first turn it on. When we get to the boot camp, it's easy. All you do is you just plug the valve at the top, and then it fills up. When the oxygen therapy is discontinued, remove the mask from the patient's face. There's no reason to keep it on there, and it actually hinders their ability to breathe if there's not oxygen flowing. It's not like it's got a seal, so they can still get air in it. But I mean, you hear people complaining that they can't breathe with a piece of cloth over their face. You're really going to struggle with this. All right, a pediatric non-rebreathing bag is for infants and kids, and the only difference is just smaller. Nasal cannulas. These are the ones you see where they're like the little prongs that go in people's noses, and you'd be surprised how often you see these things put on weird and not accurate. They're not right. So these deliver oxygen through the prongs. There's no reservoir bag. They're breathing in a mix of the 100% oxygen and then the room air around them, right? Because, I mean, that's not plugging up their entire nostril, or typically it's not. These can provide 24 to 44% of the air that they breathe as being oxygen. Remember, regular room air is 19%. So this is a small increase. We set the flow meter. It says 1 to 6. Typically, I would say the minimum would be 2. So if you're going to do a non-cannula in your evals, 1 is fine because that's what's in your curriculum here. But I tend to say start with 2, and you can go up to 6. So 6 is the emergency setting for a cannula. Any higher than that, you run the risk of blowing the tube off of the tank whenever you get it up that high. Same thing with the non-rebreather. 15 is considered the emergency setting for a non-rebreather. Some regulators will go higher than 15, some won't. The important thing there is you don't go over 15 liters, because if you do, the amount of pressure coming out is going to push the tube off. You're going to hear it keep popping. And if that's happening to you, it's because you've got your pressure too high. For patient comfort, flow rates above 6% or 6 liters are not recommended. I don't do a lot of war stories, but I'm going to tell you this one. So there's a nursing home that I used to make frequent visits to, and they was always calling me because they would have a patient with trouble breathing. More times than once, which is the real sad thing. More times than once, I walk into the room and find out that the reason the patient is having trouble breathing is because they hooked the nasal cannula up to them. They tried to crank it to 10 liters. It kept popping off. So they wedged it up to the point where you almost couldn't get the tube off of the regulator. So it wasn't going anywhere, but they cranked it up so much that those prongs are in your nostrils. All right. They're not just blowing on you from the front or anything like that. And so much oxygen was flowing through that their nose was flaring out. They couldn't take a breath because it was basically choking them out. That was the problem. All you had to do is I'd walk in, I'd turn the nasal cannula down to 4. You were right between 2 and 6, and you could just see the patient just, So, nasal cannulas, no more than 6. When you anticipate a long transport time, you can consider using humidification. Those are actually like bottles of saline that are designed to be hooked up in line between your O2 tank and the tubing that runs to your patient. So that as oxygen goes through, it's going through the saline and it's getting moisturized. Because if you're going to be breathing this in for a long time, there's no moisture inside those tanks, or they shouldn't be at least. It'll dry out your cavity, your sinuses and everything, and your patient's not going to be very comfortable. In the pre-hospital setting, a nasal cannula has limited use. However, actually, I kind of disagree with that. I think that you can't really go wrong with a nasal cannula, especially with us trying not to put patients at 100% O2 anymore. If somebody's legit hypoxic, like really, really low numbers, they're turning blue, they're losing consciousness, then yes, go straight to a non-rebreather. But if they're just, you're just putting it on them because you think that you need to raise their percentage a little bit, a cannula is a good place to start. A patient who breathes through the mouth or has nasal obstruction will get little to no benefit of a cannula. Always try to give high flow oxygen through a non-rebreathing mask. If you need to go over 6, if 6 liters is not enough for what you're trying to do, then yes, absolutely take out the cannula and put on a non-rebreather. All right, Venturi masks. All I'm going to say about these is I've never seen them in the field, or we've used them for, or at least let me take that back. We didn't even use them. We just carried them on the plane. If you look at the picture, these are preset. Instead of having a dial, you at the end of that blue tube, you can pop off that where that one's got an orange one that's connected to the tubing. You pop that off, and then you put in the color code of your choice, whatever one you want, and that sets the amount of oxygen that goes through the tube to the patient. There's much better ways to get oxygen delivery to your patients out there. I don't know anybody that still uses venturi masks outside of a hospital. Some hospitals will use them. The RTs, respiratory techs will use them, but in EMS, we just want you to know that they exist. All right, so I'm not going to really go too much into that. Tracheostomy masks. So if you have a patient that is not breathing through their mouth and nose anymore, they have a tracheostomy. A nasal cannula is not going to do any good. So there's a couple things that you can do. All right, tracheostomy masks cover the tracheostomy hole and have a strap that goes around the neck that just basically holds it in place. If you have to bag your patient, pop the face mask off of the BVM, all those connections are universal. So you can pop off the face mask, hook it to the tracheostomy tube, and then you can bag your patient through the port in their neck. You can, when you suction, if you need to suction their airway, that's what you're going to suction. You're not going to basically not going to do anything with their mouth and nose. Everything's going to be going through that port. If you're going to just try to hook up oxygen to them, there is a way. I'm going to tell you this as something to take with you into the field, but you didn't. I'm not telling you this as I know this for a test because it's against manufacturers' recommendations to do this. But you can disassemble a non-rebreather so that that white piece that feeds the oxygen into the face mask will actually fit the port on a tracheostomy tube. That way you can deliver 15 liters of oxygen to your patient. Right here, you see them doing it in what they call a blow-by method, where the mask is still there and it's just blowing into the over the port so that the lady in the picture can take a breath and get 15 liters. The only problem you're going to really run into this is you got to hold the mask. Now you got a hand that's stuck there, as opposed to just normally being able to put this thing on somebody's head and have it strapped in. Humidification. Again, you really only see this on extended transports. It's just a water bottle that's designed to fit in line with your oxygen delivery so that it's humidified oxygen coming out. Dry oxygen is not considered harmful for short-term use. So if you're anywhere in this area where I'm at down here in South Mississippi, major cities, if you've got a 3-hour transport, you might want to put humidified oxygen on somebody. If you're driving for 30 minutes or 45 minutes, it's really not that bad. Hour and a half, I would start considering it. You basically just watch your patient. If they start to fidget, tug on the nose, rub their nose, that kind of thing, that lets you know that their sinuses are drying out. We need to use some humidified oxygen. All right, so everything we talked about so far with the oxygen tubing, the non-rebreather, the nasal cannula, those are all for your patients that are breathing normal, right? They're 12 to 20 times a minute. They have good tidal volume, good depth, good rise and fall of the chest. You don't need to bag them or anything like that. They can breathe on their own. Now we're going to talk about what you would use if, when you assess your patient, you find out that they're not breathing adequately and you need to breathe farther. Assisted and artificial ventilation techniques are probably the most important skills in EMS at any level, all right, be it the EMR all the way up to the paramedic. In fact, one of the things that I hate seeing is that we oftentimes throw the BVM at the new guy and say, here, bag the patient. Really, that's a bad habit, because as easy as it is to do, there is some knowledge that needs to go with it to know if you're doing it right. Anybody can squeeze the bag, but you got to know when to not squeeze it as much, when to squeeze it more, all that stuff. Basic airway and ventilation techniques are extremely effective when administered appropriately. Mastery of these techniques at the EMT level is imperative. An EMR needs to know this stuff. An EMT absolutely needs to know this stuff. Patients who are breathing inadequately, which is too fast, too slow, or not enough tidal volume, are usually unable to speak in complete sentences. And like I said, the worse it gets, the less they're going to say without having to take a breath. Fast, shallow breathing can be just as dangerous as very low, slow breathing. So you're going to follow the standard precautions as needed when managing a patient's airway, gloves, that kind of thing. If you see somebody in respiratory distress or failure, time's not on your side. You very quickly know where your BVM is in your bag. You don't want to be sitting there fumbling around trying to find it while your patient's suffocating. Um, in fact, when you build your bags or when you go into work, if you go to an agency or something, the first thing you should do, even if you've done it every day for 20 years, go in, verify where your items are for your, like your tourniquet, your BVM, those kind of things. Because what if somebody moved it the shift before, or they rearranged the bag, that kind of thing? Those items are not the things you want to be fumbling around for when you need them. If you're looking around for 4x4s, that's one thing. If you're looking around for the BVM, that's a problem. Two treatment options are available to you. You have the assisted ventilation and continuous positive airway pressure, which is CPAP. CPAP is still kind of new, at least as far as EMS is concerned. I mean, it's been around for a long time for sleep apnea and things like that, but turns out it's really, really handy for CHF patients and some COPD patients and stuff like that. But the BVM is what I'm going to have you. I'm going to give you guys basically mastery level training for that, and show you how you can use the BVM to mimic a CPAP in case you don't have one, so that you can save somebody's life in congestive heart failure with just the BVM, if there's nothing else there. The purpose of assisted ventilations is to improve the overall oxygenation and ventilatory status of the patient. Signs and symptoms of inadequate ventilation we have beat to death. Basically, it's altered mental status, anxiety. That's the first things. Inadequate minute volume, so their breathing, their rate might be fine, but the depth of their breaths are not adequate. Excessive accessory muscle and use and fatigue, so the more that they struggle to breathe, the tighter they're going to get. To assist a patient with ventilations using a BVM, explain the procedures to the patient. Always tell them what you're going to do. Place a mask over the patient's nose and mouth. Squeeze the bag each time the patient breathes, maintaining the same rate as the patient. After the initial 5 to 10 breaths, slowly adjust the rate and deliver an appropriate tidal volume. And then adjust the rate and tidal volume to maintain an adequate minute volume. So this is basically for somebody that's in distress. They're still conscious. You want to time your breathing for their breathing, and you want to start off small and then slowly build it up as necessary or bring it down as necessary to where their breathing is as much on their own as possible. You want to do as minimal positive pressure as possible, because we don't breathe that way. We breathe negative. You're just assisting them with this. For artificial ventilation, that means your patient's not breathing at all, and you need to provide the breaths completely with the BVM. Once you determine that a patient is not breathing, begin artificial ventilation immediately. And we have a couple ways of doing this. You have the mouth to mask technique, mouth to mouth. We have the BVM, which is what you're going to use as an EMT, and we all carry the BVMs. They're cheap. Normal ventilation versus positive pressure ventilation. So we talked about that. We breathe. Normal ventilation is the negative pressure, right? Our chest expands, pressure kind of falls in to equalize. We breathe out, our chest contracts and gets smaller. We build up pressure in our chest, and then the air comes out to equalize. Sorry. Positive pressure, though, is what you're doing when you're using a bag. They're not pulling that air in by breathing. You're actually pushing that air in, and you're pushing against the diaphragm, which is a very large muscle. So you're having to put enough pressure into them to push that to lift the chest, preferably not pop the lungs. That's always nice. And also ride that line where you're not putting so much air in that you're putting it into their stomach. More volume is required to have the same effect as normal breathing, because again, you're having to put enough in there that it actually moves those muscles. Air is forced into the stomach. If you're not careful, this causes gastric distension, which you saw some people mention in the chat room earlier. That can result in vomiting and aspiration and the god awful worst smell that you'll ever see. An easy way, if you're going to bag a patient, an easy way to know how fast you need to bag. If it's an adult, we breathe 12 to 20 times a minute. So a breath every 5 to 6 seconds puts you at 10 to 12. If you're breathing for a child, it's every 3 to 5. If you're breathing for an infant, it's every 3 to 5. So This is an exception to the 10-second rule. If you're ever wanting to just breathe for somebody and that's all you're doing is just bagging them a breath every 5 seconds, and it doesn't matter what their age is, doesn't matter what their size is, that's a good rate. All right, because it's the common number for all of them. Mouth to mouth and mouth to mask is basically the same thing. One has a barrier and the other one doesn't, but you're still using your air to breathe for them. Now, I think we talked about this earlier. Why, if we breathe out carbon dioxide, right? Why would mouth to mouth be effective? In fact, mouth to mouth is actually the most effective. So if you take safety out of it, it's even better than the BVM. BVM is better because it keeps you safe from whatever your patient may have. But why is that? Why is it that if I use mouth to mouth on somebody, that's a good thing? I mean, I'm exhaling carbon dioxide. If one of y'all knows, you can unmute and say it. Bueller. Nobody. Okay. When you breathe in, best seal, can't overrun. Okay, you're right. Mechanically, those are the best. But from a airflow standpoint, when I breathe in, the only oxygen that's being replaced with carbon dioxide, there you go. John, you got it. Dead space air. All right. Only what's down in my alveoli level is turning into carbon dioxide. When I breathe out, all the air that is in my lungs and my trachea, bronchioles, all that stuff that didn't make it to the alveoli, all that's still regular air. So when I breathe into somebody else's mouth, that's what they're getting. Oh, no, you're fine. That's what they're getting though. You're giving them your dead space air that is still 19% oxygen, regular air. It's really good. You also know when you've made their chest rise or fall because your face is right there to see their chest rise, and that's how we know when we've given enough air. You're not gonna squeeze the whole bag of a BVM when you're giving somebody a breath because you'll pop their lungs, especially if it's a kid. In fact, a lot of agencies now have gone to using pediatric BVMs instead of the adult bags because people, when they get that tunnel vision, they start cranking the whole bag to capacity. And the adult bag is just too big for most lungs. I mean, unless you're working on Shaquille O'Neal or somebody like that, that BVM is going to be too much if you squeeze the whole bag. Signs of adequate ventilations, the patient's color improves, especially if they're already blue. That'd be one of the first things you're going to see. Chest rises adequately. That's when you know you've given a good enough tidal volume breath. When you see the chest rise, at whatever point you're at, squeezing the bag or whatever, that's where you stop. No resistance when ventilating. It should not be hard to bag your patient. And you hear and feel air escape as the patient exhales. To increase the oxygen concentration, administer high flow oxygen at 15 liters a minute through the oxygen inlet valve of the bag. Now, I'll say this too: when it's a non-rebreather, it's very important that the reservoir bag, is inflated. If you're hooking up oxygen to your BVM, a lot of them come with a reservoir bag that you can inflate and everything, but that one does not have to be inflated to give your patient 100%. Because the first thing that's going to collect that oxygen is the bladder that you squeeze, and then the reservoir bag will fill from there. So that's okay. But yes, the non-rebreathers must have to fill those up. All right, this is a picture of your bag valve mask for anybody who's never seen it. So you have your pocket mask face seal at the far in the corner of the picture. That blue football looking portion, that is the bladder that you're going to squeeze. And then you have your reservoir bag at the back with your oxygen tubing connected right next to it. The oxygen is going to fill the blue portion first, and then it's going to overflow into the reservoir bag. So for these, it's okay if you don't wait for that huge bag to inflate. That's fine. You can go ahead and start bagging your patient. Like I said, that's just not the case with the BVMs. Oh, I'm sorry, with the non-rebreathers. Those do have to be inflated. All right. If you're having difficulty ventilating with the BVM, you can switch to another method. A lot of times it's just a poorly opened airway. So drop the BVM for a hot second, redo the head tilt chin lift, make another seal, and try again. If after 2 attempts you still can't get it to work, you may have to try a different method. Pop the mask off, stick the one-way valve on it, and try doing mouth to mask. See if that helps. Whenever possible, work with your partner to provide BVM ventilation. It's much easier to give adequate breaths with 2 people, one person holding the seal and one person actually doing the squeezing the bladder. It's possible to do it as a one rescuer, but it's really crappy. It doesn't work very well. Most of the time, the seal's going to break and you're going to blow the air out around the cheeks, or you're just going to put it in their stomach. But that, you know what? But I mean, a lot of people they don't have the manning for it. So you run into that issue where you would love to have 2 people operating the BVM, you just don't have it. But yes, if you can, and you can even get a bystander, you're going to say, hey, you come over here. I'm going to make this seal because it takes me longer to give you instructions for that than it does to tell you just squeeze half of the capacity of this bag. That's an easy way to do it. You can have the mom if it's a kid. You can have the bystander or whoever. You just tell them, say, hey, do me a favor. Every 5 seconds, I want you to squeeze half of that bag, and then you just focus on holding the seal, and making sure that they have an easy way of doing it. Gastric distension. Gastric distension is where you get all that gook and air into the stomach instead of the lungs. So when using a BVM or any other ventilation device, be alert for gastric distension. And no matter how good you are, if you're after a while of bagging, you will eventually get this. Most commonly affects children, but it can affect adults too, especially if you're using a BVM on them. The thing about it is that just the way that kids' anatomy is, because it's so soft, they don't stand up to pressure very well in their airway. It does happen very fast in kids. This is most likely to occur when you ventilate the patient too forcefully or too rapidly with a BVM or a pocket mask, or if you use too much air, too much capacity. Like I said, the overflow dumps into the stomach, and also if your airway is not properly secured, if you don't have them in a good head tilt chin lift or something of that sort, you can actually put air into the stomach. This can occur when the air is obstructed as a result of foreign body, depending on if their actual trachea is clogged because of a piece of steak or whatever. The air from your BVM may have nowhere else to go but the stomach. So for this reason, and definitely not only this reason, but give slow, gentle breaths during artificial ventilations over 1 second. It's not just that. Think about how we breathe, right? Not every breath is a gas. We don't suck air real fast. So you're mimicking a body function when you do this. Same thing with compressions on the chest for CPR. You're doing it because the heart's not beating, so you're doing it. When you're bagging a patient, it's because they're not breathing, so you're doing it. You want to make it feel normal to them, make the body think that everything's going, and hopefully it will eventually pick back up. So breathe gentle over a second. Give them a couple seconds to exhale everything. Breathe again slow over a full second. Let that half bag squeeze take about a second to complete, and then you're good. As your compliance decreases, you'll notice it becoming increasingly difficult to squeeze the BVM to get air into the lungs. And when they're really, really bloated, it's going to look like they're pregnant or swallowed a basketball. The stomach really distends a lot. Severe inflation of the stomach is dangerous. It's definitely going to make for a bad day in the ambulance if they throw up. Passive ventilation. This is the process of expansion and contraction of the chest, creating a pump for air movement in and out of the chest. During cardiac arrest, you're responsible for providing chest compressions to circulate blood and artificial ventilations to oxygenate the hemoglobin. So that's that 30 to 2, right? You give them 30 compressions, 2 breaths. But because chest wall movement affects your ventilation, your ability to breathe. Oh, hold on a second. When you have gastric distension and the fluids start coming up, ball game over. Yeah, because now you're going to spend all your time suctioning. But because when we breathe, our chest wall is involved in that. When you're giving compressions to somebody, they are breathing a little bit, um, just from your compressions. It's not much. It's not like breathing with a BVM, but it's there. It's called passive ventilation. And there's actually, I don't know if they're going to put it in the new CPR standards because we're still waiting until October 21st when they come out. But something you can do for your patients to really help their chances of survival if you're doing CPR is to understand that this process exists. So while you're pumping on the chest and somebody with the BVM is sitting there waiting on you to reach 30 for them to take 2 breaths, they can hook up a nasal cannula and put it on your patient's nose so that that passive ventilation from your 30 compressions is pulling in better oxygen. All right, so it helps them get more oxygenation during those 30 compressions when they're otherwise not getting a breath from the BVM. That's just something to think about. I know that the latest studies that have come out from ILCOR that are on cardiac arrest, and that's what AHA and all the other organizations they build their curriculums off of, they've been really talking that up. So I wouldn't be surprised if we start seeing that at the healthcare provider level where they say put a nasal cannula on them if you can, so that your compressions are sucking oxygen into their body better. In passive ventilation, air movement in and out of the chest cavity occurs passively as a result of compressing the chest. We just talked about that. So let's go ahead and move on to the next one. Manually triggered ventilation devices, also known as flow restricted oxygen powered ventilation. Has anybody ever seen these in an agency that you've worked for? I have not. I've learned about this since I first became an EMT because they used to be really common. It's almost like using a tire pressure, a tire air filling thing to pump air into your patient's lungs. Great way to pop them, really, if you think about it. I think that's why nobody uses them anymore. This allows a single rescuer to use both hands to maintain a mask to seal a face while providing positive pressure ventilation. So you get to, instead of having to operate the bag on the bag valve mask, you just use both hands to hold the seal, and this device shoves oxygen into their throat automatically. The thing about it is you have to set the amount of air. It's like using a vent. So you set the amount of air that you want to give it to them, and if you don't set it right, you push too much air in and it pops their lungs. This reduces rescuer fatigue associated with the use of a BVM on extended transports, but it can also very greatly increase the time, or I'm sorry, decrease the time to your gastric distension and to the point where your lungs don't really deflate anymore. The disadvantages may be difficult to maintain adequate ventilation without assistance. Should not be used routinely because of high incidence of gastric distension. I was just saying that. Should not be used in patients with COPD or suspected cervical spine or chest injuries because you don't want, I mean, these things are, when you set it, they're going to push that air in. If they meet resistance, it's going to push through the resistance, and that can actually cause some harm to people that have injuries in that area. All right. Automatic transport ventilators, resuscitators. These are basically, we hear about these a lot with COVID. When COVID first came out, that was the big thing. We're always going to be short on vents, and I don't know why, to be honest with you. I mean, vents are not new. I don't know why there's not more of them out there, but that was one of the big things, was that they didn't know if we were going to have enough for everybody. But these things, I'll just say vents are going to be, that's basically where they just vent the patient for you. So instead of using a BVM, you can set it to where, how often you want it to breathe, how much air you want to put in, how much air you want to leave in. You can adjust PEEP to stay where it says, you know what, we want to keep the lungs 10% inflated. So I'm going to set that, whatever. If you use these in your organization, I pretty much promise you that you won't be making the decisions on the numbers that you set. You're going to have to get med control on the phone, tell them what you got. You're going to need to know things like the patient's weight, size, gender, things like that, so that the doc can give you the best guess as to what amount you need to use, because he can't see the patient in person yet. A lot of like your critical care ambulances carry these, but usually you see them in the hospital. These are great because if once you do get it set, you just leave it alone. Unless something gets bumped, then it just does its thing. And they have these also have a lot of like pressure relief valves and everything. So if they meet resistance, it just blows the pressure off. It doesn't pop anything. Um, I loved using these when we were on the planes. They were fantastic. I just like set it, forget it, and as long as nobody went up and bumped it, I didn't have to mess with it. All right, CPAP. Like I said, these are new. We use these a lot for. You can use these for asthma. You can use these for COPD patients. You can use these for CHF patients. It's fantastic as long as they are alert. If they lose consciousness, can't use the CPAP, which I'm sure we'll get to that here in a second. These are becoming very, very common. And even when they first came out, they were for whatever reason they're like, oh no, we can't let the EMTs do this. It's got to be a paramedic, which is stupid because it's a non-invasive thing. But they're becoming more and more widely used at the EMT level, which is nice. So you guys get to learn about this. CPAP increases pressure in the lungs, opens collapsed alveoli, pushes more oxygen across the alveolar membrane, and forces interstitial fluid back into the pulmonary circulation. And that right there is what saves CHF patients because that's their problem. You can do that with the BVM. Remember, like I said, there are a lot of patients you may not be able to use CPAP on. So if you can't do it with that, you can always do it with the BVM. It's just now you're the one having to maintain it. It takes a little bit more effort. The therapy is typically delivered through a face mask held to the face with a strapping system. So it kind of looks like a regular face mask, like what's on your BVM or what's on your pocket mask, but it's got this little green like over the main port where you would connect the BVM to it or something like that. There's a green ring with 4 little hooks coming off of it. And then you have the face strap goes around the back of the head and then connects to those hooks so that it holds it in place. And it kind of operates like how our SCBA operates in the fire department. You've got that little click valve that it won't just let air flow through, but it builds up pressure that's held in check by the tubing outside the mask. And then when the patient tries to breathe in, it that's when it just like the tube cracks open or the valve pops open and then that air is pushed in. And it is positive pressure, but it's done at the patient's will. The only thing is the patient has to be awake to be able to maintain that. So a good seal with minimal leakage between the face and the mask is essential. If you don't have that, when then the patient won't be able to create enough negative pressure inside the mask to pop the seal open. Many CPAP systems use oxygen as the driving force to deliver the positive ventilatory pressure to the patient. So it basically just connects directly to your O2 tank. Use caution with patients with potentially low blood pressure because CPAP causes a drop in cardiac output. That is something that's also good to know when you're talking about CPR in general, is that positive pressure ventilation actually puts pressure on the cardiac system and it'll push cardiac output down. So that means that your blood flow is going to slow. And if you're already fighting low blood pressure or a bad pulse or something like that, that's going to make that situation worse. The easiest way to know that is if you put this on your patient and then they pass out on you, it was probably for that reason you have to take it off. And if that's the case, then when you take it off, usually they bounce back. They're like, "Whoa, what happened?" All right, indications for CPAP. The patient is alert and able to follow commands. The minute they start to pass out on you, you have to take it off and switch to the BVM if they still need it. The patient displays obvious signs of moderate to severe respiratory distress from a condition such as pulmonary edema or obstructive pulmonary disease, COPD. The patient is breathing rapidly, so somebody's breathing over 26 times a minute. You put that on their face, they breathe that first time, that pops them, they get surprised, like, holy crap, now I got a lung full of oxygen. It will slow them down. The pulse ox reading is less than 90 because sometimes the reason that they're not getting their oxygen is because their airway is constricted to be like bronchospasms or COPD, asthma, those kind of things. So CPAP is basically it's an automatic BVM. These are all the same indications that you would use for a BVM, except the patient is alert. Because we use BVMs on unconscious people too. Contraindications. If your patient is in respiratory arrest or otherwise, well, I mean, that is just it. Yeah, they're not breathing, because they're the ones that activate that pressure. They have to take a breath to open the valve to allow the oxygen in. If they're not doing that, then CPAP's not going to do anything for them. Signs and symptoms of a pneumothorax or chest trauma, we don't use CPAP. Patient who has a tracheostomy, mainly because there's no way to connect it. Active gastrointestinal bleeding or vomiting. The thing about it is that mask, it takes a little bit to put it on there, which means it takes a little bit to get it off. If they're still vomiting, that's going to, it's going to take you a minute to get to where you can suction them because the mask is there and it's fastened to their face. Patient who is unable to follow verbal commands. And always reassess the patient for signs of deterioration and or respiratory failure. If you put this thing on them, hopefully they're getting better. If they're not, that means you need to take it off and switch to the BVM or just try something else. All right, we'll get to the application at boot camp. I'll show you guys how to do that. And I'm going to go over it here. It just doesn't make sense. Complications with the CPAP. Some patients may find it claustrophobic, just like they would the non-rebreather or anything else. The only problem is like if somebody with a non-rebreather is claustrophobic, you can just kind of grab the mask and pull it off their face so they're still getting airflow. But you can't do that with CPAP because you have to have that sealed. So if they don't like it, if they just flat out can't tolerate it, there's no alternative really, because the alternative is a BVM. They're going to have the same problem. So coach patients through this processes rather than forcing the mask on them. You can kind of tell them, here's what I'm going to do. Here's what it's going to do. Here's what happens. It's clear. You can see around it. You can see through it. All it is a mask. Try to get them to be able to handle it. If they can't, then you just pull it off. But hopefully they will listen to you. And if not, they're going to pass out, and then you're going to wind up using the BVM. Due to the high volume of pressure generated by CPAP, pneumothorax is a risk. You do run the risk of popping a lung with these. High pressure in the chest can also lower their blood pressure, just like we talked about with the BVM. If the patient shows signs of deterioration, remove the CPAP and begin positive pressure ventilation using a BVM with oxygen. Basically, the CPAP is a BVM alternative for a conscious patient. If they go unconscious, you're just stuck. We're almost done. We have special considerations, and then we have choking, which I'm not really going to worry about choking too much because you went over that in CPR, and there's nothing really different about it at the basic level. So we're going to do special considerations, and we're going to call it a night. Stomas and tracheostomy tubes. You may run into patients that have these. Patients who have had a laryngectomy, which is a surgical removal of the larynx, have a permanent tracheal stoma. This is basically an opening in the neck, like what you see in the picture, that connects the trachea directly to the skin. This is also known as a tracheostomy. All right. Patients may have other openings in the neck depending on the type of operation performed. So ignore any opening other than the one in the midline tracheal stoma. That's the one that's for your airway. If they have holes anywhere else around the neck, don't worry about it. It is the only one that can be used to put air into the patient's lungs. Surprised we have to say that. Neither the head tilt chin lift maneuver nor the jaw thrust is going to help open a patient that's got a stoma, because those moves are for the tongue, remember. If they have a stoma, then their airway opening is down around the Adam's apple. It's not that high. The tongue's not an issue. If the patient has a tracheostomy tube, ventilate through the tube with the BVM. Again, so we saw the picture of the BVM. If you haven't actually seen one in person, those masks, the part where you actually put up against the patient's face, they just pop off. And the connections for all airway equipment, be it stomas, tracheostomy tubes, BVMs, one-way masks, all that stuff, they're all the same size. They're all universal. So you just pop the mask off your BVM, it sticks completely into the stoma connection, and then you can bag your patient that way. A standard, I just said that. If you do have to bag a patient with a stoma, use 100% oxygen. Just go ahead and hook it up to them and give it to them. If the patient has a stoma but no tube is in place, like what you saw in that last picture, you can use an infant mask. If you've ever seen an infant mask for a BVM, they're just perfectly round. They look like a donut. You can just put that over the hole and breathe with it. It'll make a seal typically. because it's small enough in diameter to do that. Seal the patient's mouth and nose with one hand to prevent a leak of air through the upper airway when you ventilate through a stoma. Again, air is going to travel in the least resistance, right? You push in through a stoma, it can either go down and have to deal with the pressure of lifting the chest and pushing the diaphragm, or it can just go up and out through the mouth and nose. So make sure you seal the patient's face when you're doing that. And if you're paying attention, it's kind of self-explanatory or self-correcting, because the first time you give a breath and it sounds like they just snorted out their nose, you know that that's where the air is going. So your second breath, hopefully you'll have your hand there. If you can't ventilate a patient with a stoma, try suctioning the stoma with the mouth, and the mouth with a French or soft tip catheter, something that you can actually maneuver around in there. But you're gonna do it the same as you do with the mouth. So, put it in and then suction on the way back out. Seal the stoma while giving mouth-to-mouth ventilation. If you can't get the stoma to work, if it's too clogged up, then seal the stoma off with your finger or with a glove, like an extra glove or something, and then you can give mouth-to-mouth or mouth-to-mask at that point. All right, I think that's going to be it. We're not going to talk about choking tonight, just because it's, like I said, that is CPR. We teach that in CPR. It's the Heimlich maneuver. You do that until they pass out. They pass out, you do CPR. Okay, we'll talk about these last two slides. So, facial bleeding. Airway problems can be particularly challenging in patients with serious facial bleeding. I've seen some pictures on a Facebook group y'all can look up. It's called Savage Paramedics, where they'll put like traumatic scenes and some pretty gnarly, messed up stuff, and like, what would you do? That kind of thing. There's quite a few pictures when I was newer at being an EMT, where I was like, I don't freaking know, quit, go find another job. Because it's like, oh, I would want to do this, but I can't because he doesn't have half of his face, that kind of thing. The issue though is that here's the problem with it. Anybody that's ever tried to shave their face, all right, guys, you know that it can be a nick so small that you can't even see the cut, but it looks like a murder scene because you're bleeding everywhere and it doesn't stop. The blood supply to the face is very rich. There's all kinds of vascularity up there because we have so many muscles that allow us to make facial expressions. So the smallest injury can create a lot of blood. So imagine what a massive injury would do. Injuries can result in severe tissue swelling and bleeding into the airway. You may wind up having to suction somebody's airway because of stuff that's falling into it from the outside. Just be prepared for that. Is what this is getting at. You can control the bleeding with direct pressure and suction as necessary. Don't try to tourniquet the neck. That doesn't work very well. And that is it. So I'm going to give you guys your pin while I'm putting that together. If there's any questions, pop them into the chat, or you can just unmute and ask me directly. All right. Let me see if I can type this. Your pin for the night is going to be B as in Bravo, C as in Charlie, 10, A as in Alpha. BC10A. It's going to be your pin for the night. Any questions on the airway? No problem. If y'all need anything, let me know. Like I said, we did skip the stuff that involves skills, so we're gonna get to that when we get to the boot camp. That's what the boot camp is for. But your tests, if I didn't remember to take skill questions out of there, we'll make some adjustments as necessary. But do the best you can. Don't forget, we are in the extension time for Module 1, so you guys that haven't completed Module 1 yet need to get on it. We've got about a week left of that 2-week extension, and then we're going to be back on track. And this module is short, so keep that in mind. We're gonna reach the end of this module pretty fast. I don't want you guys to be so far back that you're having to deal with two module tests. But otherwise, y'all have a great night. Thank you for coming to class, and I'll see you on Tuesday night for the next one.